Hello everyone. How are you guys? Please let me know if I'm audible and visible to you guys. क्या हुआ? यहाँ से बंद होगा एक ठीक है छोड़ ये ब्लैक रे में आ रहा है इसको थोड़ा बड़ा ठीक है रिफ्रेश करके देखिए Hi guys, if you're online, please let me know if the audio video is clear. Yeah, 46. Yes, thank you. Hello Purnima, Anurag, Shabaz, Ritali. Okay guys, let's start. But before starting, I just wanted to tell you that yesterday I was looking out for some questions and I came across yesterday I was having that gut feeling is something going wrong. So mistakenly I have told the good and bad prognosis vice versa, opposite. Good evening Ramya. So please correct it there that it should be, just a second, it should be, here it should be 2 to 10 years and यहाँ पे it should be less than 2 years and more than 10 years, right? Obviously in the infants, if you give chemotherapy and all, if you start that, it is going to be a bad prognosis, especially in the infants, right? Because they are not having the mature hepatocytes, so the drugs won't be metabolized and the side effects will be much more, right? So that is there. Please correct it. Just about the age, I was having that gut feeling that good evening Sonu, good evening Sanjay, Sunil. Yes, so please correct it. Okay, I hope 64 people are there. You know, yesterday it was, I don't know, around 100 and something. So if someone misses it, please let them know. Radio jockey, yeah, I should try that, right? These people just do the entertainment, right? Over here we are studying and we are trying to make our world better, isn't it? Mahindra, Bahubali. Is it your real name? Okay, good evening. Chalo, just make the correction there, right? And while I was going through this, I had this feeling that stuff like this always happening around me. Sometime it's happened that I don't know how I got misplaced it while writing also. I had that feeling that something going wrong, but then I continued because I was not sure about it. So yeah. All right, they are coming. कहाँ से आ रहे हैं भाई? मार्स से आ रहे हैं क्या सोनू? हाँ जी. Aryan, the PDF is already on the group, right? You can go there and just get it from there, okay? Chalo ji. Can we move ahead? Okay. So my friends are giving it all, they're all, right? And I have to do this. I can't let them down. So you all are my friends, right? So yes. You all are my friends, right? So if you are giving your all, so I should give my 100% right, or rather 200%, right? So no. Hindi mix, yeah, yes, I'll try, but yes, there are our friends from the south also, they won't be understanding the Hindi, right? And that's why I use maximum of the English. Yes, right? So let's move on with the RBC. So today we are going to learn the RBC. Now, can you tell me the shape of the RBC? Can you see over here, this is the 3D structure. When we draw it in 2D, right? Abhi tak 3D drawing aaya nahi hai. So that's why on paper, what happens is we can draw the 2D structure. But what is the shape of the RBC? If I have to write the shape of the RBC, how it will be? It is circular. First of all, it is circular. Remember, there is a difference between circle and sphere. Sphere means from all the sides the radius is going to be equal. Even if you draw in the 3D, it is going to be equal. Circular means in the two direction it is going to be circle, right? So if you say this is one horizontal line, it is going to be circle, right? And if I take it vertically also, it is going to be circle. But if I take a 3D direction, it won't be circle. Okay, so that is the difference between circle and sphere. Why I am telling you such a detail in the physics? Because we'll be having one anemia which is known as hereditary spherocytosis. In that the RBCs will be spherical. There is a difference between circular and spherical. Okay, the RBCs are not at all spherical. They are disc shape and they are circular like your coin. But they are not exactly like coin. Why? Because in between they have indentation and we call that as the biconcave shape. The RBCs are circular biconcave disc shape, right? And it loves only one thing. And what? Convex नहीं होता है बच्चे, concave होता है ये. Okay? अगर आप ऐसे ड्रॉ करोगे ना तो ये वाली साइड हो गई क्या? This is known as concave. Okay? और ये वाला जो outer part होता है that is known as convex. ओके सो अगर बाय कॉन्वेक्स मुझे निकालना होगा तो ये हो गया बाय कॉन्वेक्स. ऐसे नहीं होती है, फुली हुई नहीं होती है आरबीसीज. दे आर लाइक दिस, है ना. इफ यू सी हैव अ लुक फ्रॉम द साइड, दिस विल लुक समथिंग लाइक दिस, है ना. ऐसे दिखती है. सो दिस इज बाय कॉन्केव, नॉट कॉन्वेक्स. ओके, डोंट गेट कंफ्यूज. ओके, संजय आरिफा, yes, Osama is right. Dumbbell shape again, not really, but yeah, you can say that too. Okay, so चलो हो गया हमारा फिजिक्स यहाँ पे. एंड व्हाट दे लव, they have undivided unconditional love for only one and only one thing. And what is that, है ना, which is lacking in nowadays this modern world. It is lacking, है ना. So we should learn from the RBC. What we should learn? The unconditional love, है ना, without any conditions or without any promises or without any expectation, है ना. So whom does it love? Yes, please. क्या होता है RBC में? Is there any organelles present like nucleus, mitochondria, Golgi apparatus? Anything is present? Not really. Oxygen. Oxygen comes along, right? जैसे आप किसी से शादी करते हो तो some relative come along with that as a gift, right? So oxygen comes along, but it loves the hemoglobin, है ना. So किसके नाम का सिंदूर लगाता है RBC? It's the hemoglobin. Okay. Kunj, absolutely right. Okay, because there are so many messages, I might miss your name. Okay. Don't worry. Okay, chalo. Let's move on. The blood group system that we are going to talk about. First of all, anemia, though they are important, but the short topic we are going to cover, that is going to be the blood transfusion. For that, we should know how many type of blood groups are there, how many types of blood group systems are there. Okay, there is a two different thing per se, not very important in the MCQ exam per se, but yes, we should know that there are various blood group systems. What are the blood group system? First is the ABO blood group system, RH blood group system, MNM system, Duff, Cayley, Lewis, so on and so forth. There are X and Y system, right? So there are multiple blood group systems. But the most commonly we are going to use only two systems which are standardized everywhere, because maximum people, they do have these antigen, and that's why it is standardized everywhere worldwide. And the two system that we use, that is first is the ABO system and next is the RH system. Okay, so these are the systems, they are not blood groups. Okay, so first of all the systems, and under the system we do have different blood group depending on what antigen they are containing. Okay, so what is the rarest blood group, bacho? Tell me the answer of rarest blood group. It's fun to read your comments over here. Chalo. It takes some time. Yes, it is physiology, Ankit, and I love it. Chalo. Tell me. Yes. O negative, is it the rarest system, Kunj? Think again. Purnima, think again, bache. Shabas, think again. Chalo, I'll give you the options. Definitely it is difficult, but you won't be making the mistake if I give you the options O negative, let's say AB negative, B positive, and Bombay blood group. Chalo, now give me the answer. What will be your answer now? O negative. Many of you are saying O negative, but yes, I hope you will be giving the right answer now after this, right? So I'm waiting for your answer, but till that I'm telling you that the inheritance, yes, Shabas, very good. Yes, now everybody, Adesh, someone, Purnima, yes, now you guys are absolutely rocking, right? Rutali, Lone, right. So yes, you guys are right. It is going to be Bombay blood group because this is the rarest one. It doesn't contain any RH also and H antigen also, the capital H also and the small h also, right? So yes, definitely it is going to be. Please make a note of it. And now this question is favorite. So Bombay blood group is going to be the rarest one. And this is codominance. That means, like we say in the mitochondria, it comes from the maternal side. That means the X chromosome is going to give the mitochondria. So the maternal dominance is there in the case of mitochondria, but over here when we talk about the blood group system, definitely it is going to be codominance. That means equal contribution of mother and father. दोनों का समान हाथ होता है, right? इसमें, right? Then cross matching. What is the cross matching? We have to do something known as cross matching. That means we have to check the RBC as well as the plasma against each other's blood. Suppose I am the donor and there is a patient who requires the blood. So I am going to give the blood to that recipient. Now understand, there is whole lot of process. It just not happen that जैसे movie में दिखाता है, it won't happen like blood चाहिए किसी को तो एक का दूसरे में डाल दिया. That is not going to happen in the real life, right? This is only happens in the movie that one patient or one lover just lie down and one's blood go in the another's blood, right? Another's vein. That is not going to happen. There is a whole lot of process because we want to save the patient and not kill him by the diseases like HIV and hepatitis. So that's why we have to go with the procedures, right? So there are two types of cross matching. Please remember, direct cross matching and indirect cross matching. इस पे question आया हुआ है, what is the major cross matching? Which one of the following is the major cross matching in your FMG exam itself, right? So we should know how to remember. See over here, in the major, we know that the antigen is present on the RBC. So we want to check the antigen. So that is going to create the nuisance in the recipient's blood. So we do not want any nuisance from the donor's blood. Okay, otherwise the whole lot of reactions are going to take place. So that's why please remember that this is going to be the RBC and this is going to be the plasma. So please remember the P comes because if I say R and R, donor में भी R आ रहा है and recipient में भी R आ रहा है. So we cannot say R for R, right? We cannot say that. Remember that the P is only in the recipient. So that's why we are going to say that the plasma of the recipient, we are going to check against the donor's RBC so that the plasma should not contain any antibodies against the antigen which is present in the RBC. And minor mein you are going to reverse that, that is the plasma of the donor and the RBCs of the recipient. Okay, so please remember this question has been already asked, so please mark it over here that the donor's ka RBC and recipient ka plasma. So if you get confused there, please check out the recipient, because if we are giving the blood to someone, now the recipient, we want to save the life of recipient, so recipient becomes more important here and recipient mein P aa raha hai, so P is also there in the plasma. So that's how we are going to check. This next thing, the minor cross matching, the plasma of the donor will be checked against the RBCs of the recipient, but that won't create much of the nuisance because plasma is again going to get diluted and the kidney removes it out very quickly, and as soon as we are going to drink the water, the clearance of the plasma is much earlier as compared to the RBCs. RBCs are going to live there unless and until their lifespan gets over, right? So don't be afraid to start over. It's a chance to build something better, isn't it? RH positive, RH will come over there. Yeah, they will give directly in the movies, but even in the movies, they do not even ask what is your blood group, hai na? They just ask, are you ready to give the blood, hai na? And are you ready to kill the patient, right? So yes. Ramya, don't worry. We are going to cover everything in the hemat, RBC as well as platelets, and we are going to some questions, right? Not many, but some questions are there. Now let's move on to the ABO blood types, right? So first thing is, there are 4 types of blood group depending on, I told you, antigens. Okay, now first of all, there are 2 terminologies that you have to focus on. And what are those terminology? First of all, see over here, antigen and antibody. Antigen mein jan aata hai, so please remember, antigen that is present on the RBC membrane, it is a specialized antigen. We cannot find this antigen anywhere else rather than the RBC. If you are specifically talking about the antigen of the RBC, we are going to call it as agglutinogen. And if you are talking about the antibody which are going to act on the RBCs, again it is going to be specific agglutinin, right? Why? Because they cause agglutination, right? So agglutinogen, agglutinin will cause agglutination. That means antigen antibody reaction, right? Very easy. Now see over here, depending on what antigen we are having, the same blood group we will be talking about. So suppose someone is having this A type of antigen, then his blood group will be A. If he is having B type of antigen, the blood group will be B. And if he is having both the type of A and B antigen, the blood group will be called AB. If he is having none of them, nor A, neither A nor B, then it will be called as O, 0, right? Under no antigen, that means it is going to be O and O blood group. Now, antibodies. If suppose someone is having A antigen and A antibody, what is going to happen? Obviously, the agglutination is going to happen, right? Roy, it's never too late if you are going to be willing, if you want to, you know, crack this exam over here. If you give your 10 hours daily classes and revision, definitely you can crack the exam, because this is again not a competitive exam, it's a screening test. You have to take minimum 150 marks. Okay, you can do that. They're not asking you to crack the exam with 200 plus marks. You don't have to take a rank over here, you just want to crack. So within 10 hours, if you read every day 10 hours, because the time is only even less than 1 month, so yes, you have to read at least 10 hours. Classes ho rahi hai 3-4 घंटा, so at least read after that at least 2 to 3 hours. If the daily classes are going on, at least जो भी क्लास हो रही है उसका रिविजन आपने करना है. एंड एटलीस्ट आई से दैट एवरी टॉपिक, for every topic you can solve at least 10 questions. Like yesterday we had the WBC ka, so WBC ke ALL pe 10 questions, AML pe 10 questions, you can solve like that. Okay, so you'll get an idea ki how to solve the questions. Right, let's move on. If I said that a person is having both A antigen also A antibody, now what will happen? He's containing the antibodies against A. Obviously they are going to act and they will attack on the A antigen. What will happen? They will attack on the RBCs and they will destroy the RBCs. The hemolysis will occur. So that's why one scientist gave his entire life to study the RBC antigen and antibody, and who gave this system. Who is the scientist? Tell me the name. He is going to be, yes please. Who is going to be the scientist? Please remember the name, Landsteiner. Okay, so he is the scientist, that is Landsteiner. You should not remember any. I do not remember the name of many of the actors, actor, film, है ना? I do not carry that burden of information in my brain, because again your brain space is limited. What you feed in that is important. I do not know any lyrics of any song. Yes, there are some songs which, you know, suits me out, or if I'm feeling low or something like that, I'm not feeling like studying, but I have to, so I listen to a song, which there are some, right? But yes, again you have to know the scientist's name. Full respect, right? So Landsteiner, he gave the law. What he says that whatever antigens are there, Against that, the antibody will not be present, and whatever antigens are not there, those antibody will be present. Why? Because again, they will be called as non-self antigen. Suppose over here, let's take the example of type A. In that, A antigen is there, but B antigen is not there. If the B antigen enters in the patient's blood, what is going to be happening? That antigen will be called as non-self antigen. We want to kill that, otherwise it can cause the problems in the different areas of the body, and that's why we do have antibody against that antigen, right? So this is the law. That means if the antigen is present, the antibody won't be present, and if the antibody is present, the antigen won't be present. Okay, so that is the Landsteiners law. So that is given over here. What the Landsteiners law says, that agglutinogen, if it is present, the antibody will not be present in the plasma. If the antigen is absent on the RBC, because antigens will be on the RBCs and the antibodies are present in the plasma, okay, and they won't be present if the antigen is present, and vice versa. If the antigen is not present, definitely we need the antibody, because it is not our own self antigen, isn't it? Everything clear? Because this is going to help us in the blood transfusion medicine also, right? So who is the universal donor if I talk in terms of this? Because we do not give the Bombay blood group, that is going to be the best one, because it does not contain the capital H antigen also. But remember, that is the rarest blood group. If the Bombay blood group patient comes, what you will give, right? So we store that blood group only for the Bombay blood group person. Universal donor is going to be O negative, right? Universal recipient is going to be AB positive, right? Right. Deepak, Shabaz, Haripriya, Senthil, yes, you are rocking. Right. Let's move on to the RH. Now, RH is important. Again, you must have learned in the gynecology. Yes, I love to teach you, but again, the time is limited, so we won't be going towards the RH wala thing, that is the erythroblastosis fetalis. Okay. Now, what happens over here? RH positive and RH negative. Either the RH, that is in the rhesus monkey, this was found first of all, so that's why it is known as RH. That is one type of antigen which can be present depending on what we are going to decide whether it is blood group positive or negative. Okay. So that is going to be the second thing. And please remember, the Landsteiner and Wiener, they were the two scientists which worked on this in the rhesus monkey. With the help of rhesus monkey, they worked on it, and they found out that 85% of the Indian population, they are positive, RH positive, okay, and 15% of them are RH negative, and that's why you were right. If the Bombay blood group is not there in the option, O negative will be the rarest blood group, okay, followed by the Bombay blood group. If the Bombay blood group is there, you cannot mark the O negative, okay. Now, obviously, the same thing is over here, but understand both the things. Can you see the difference? What I told about the Landsteiner law, if the antigen is present, antibody won't be present. Antibody is present, that means the antigen is not present, vice versa. But there is a trick, that it is the exception, that the RH negative blood group do not follow the law of Landsteiner. What was that? The antigen is not present over here. The antibody must be present. But remember, it is not present because unless and until antigen is present, the antibody won't be produced in the case of RH and not in the case of ABO. So this is the slightest difference which is present in the RH blood group. So please remember, this is the exception, that RH negative. So they can ask you the question that which of the following do not follow the law of Landsteiner or Landsteiner's law, then it is going to be the RH negative blood group. RH negative, if the antigen is not there, it is not necessary that you will find the antibodies. The antibodies can be negative too, right? So that is the difference over here. Now, tell me, what are the infection to which before giving the blood to the recipient you want to check for? Okay, what are the pre-transfusion testing you want to do? I used to remember it as H3 mal-C. Okay. So what is H3 mal-C? H say 3 diseases are there. Okay, I hope you guys will tell this. RH blood group kuch nahi hai bachche. There is one antigen which is known as RH, Shabazz, that if it is present, we call it as RH positive. If the RH antigen is not present, we call it as RH negative. It's just that RH negative antigen nahi hai, तो antibody भी नहीं होगी. So that's why it is called as the exception for that law. Okay, so हमने यहाँ पे देखा था कि अगर ये ब्लू वाला एंटीजन नहीं है यहाँ पे बी में, तो ब्लू वाली एंटीबॉडीज हमें मिली थी. सो दैट इज नॉट देयर इन द केस ऑफ RH नेगेटिव. यहाँ पे एंटीजन भी नहीं है और एंटीबॉडीज भी नहीं है. सो दैट्स व्हाई दिस बिकम्स द एक्सेप्शन टू द लैंडस्टीनर्स लॉ. RH नेगेटिव एक्सेप्शन टू द लैंडस्टीनर्स लॉ. ओके, that's what I told. Yes, you guys are telling me the answer. Sarkar, right? Pia, right? Jyoti, yes. So that is there. So pehla likho HIV. Then what are the other H, guys? Hepatitis. There are two types of hepatitis. Again, hepatitis, the chronic ones. That is B and C. A is by the water, E is also by the food and water. So they will be cured. They are temporary. They won't be causing much of the loss of the hepatocyte. But B and C, they are dangerous. Okay. So hepatitis B, hepatitis C. So HIV, hepatitis B, hepatitis C, and M for, yes please, malaria. Absolutely right. You gave me all the answers over here, and this is going to be the syphilis. Okay, don't forget, they are going to give some other disease, anything for that matter. Okay, HIV के लिए वो AIDS भी दे सकते हैं. Don't get confused कि वो H से नहीं start हो रहा है, तो don't mark this, right? So please write AIDS over here too. Okay, so you are going to check for the AIDS, either the HIV or AIDS, one and the same thing. Okay, they can give any other disease for that matter, and they can ask you that whether you are going to, which of the following you won't be checking pre-transfusional testing. Okay, now overview of this system. Right, Arefa, Sunil, Haripriya, Sonu, yes, perfect. Okay, HIV 1 and 2 कुछ नहीं होता है, hepatitis B and C होता है, right? So यहाँ पे देखो, what we do is we take the blood, and I told you yesterday that the RBCs are having much more density. That means they are heavy. So if you keep the test tube for, let's say, 2 hours or so, what is going to happen? You took the blood sample. You keep it into the, what I did, I took the sample and via the syringe I took the sample, and then I kept it in the, what thing, I kept it in the test tube. What will happen after some time? I can see that the RBCs are settled down. Why? Because they do have much more density. They are heavier, and the plasma is on the top of the test tube. Why? Because it is less dense, or it is lighter as compared to the RBCs. So what is going to happen, that we can see the three things over here, that first of all we are going to see the RBCs at the bottom part, then the WBCs and the platelets, and then we are going to have the plasma. Usually the WBC and platelet combinedly called as Buffy coat. Again, no one will ask you that, which is containing less than 1%, not even 1%. Okay, RBCs are in millions. I told you it is known as hematocrit or PCV. So it is going to be 45% and the plasma is going to be 55%. So if rather than taking in the test tube, I took it directly in the blood bag, and if I keep it horizontal, so this is how it is going to look. And over here, what you are seeing, the layer where you can see the mixture of red and yellow, that is going to be the Buffy coat. Okay. Now what we are going to do is, there is a bag via which we are going to give the compression. Okay, इस bag को we are going to compress from both the side, and we are going to give 2 outlets to 2 different bags. So one outlet from top is going to this bag, and one outlet from the downwards, it is going to the another bag. So what is going to happen, if I start compressing, the outlets will be transfusing different part in the different bags. Okay, as simple as that. So this yellow part, unless and until it gets into the another bag, that is going to be, I'm going to compress it, and that is going to contain the plasma only, and in the another bag I'm going to take the RBCs. Okay, so that is going to be the system which we work towards. So this is the blood, and we are going to have 2 different things now. RBCs will be there and the platelet rich plasma, but because again the platelets will be lighter as compared to the RBCs, so definitely they will go in the plasma itself. Hematocrit, yes, Sonu, good. plasma and hematocrit, we are going to separate them. Now, this platelet-rich plasma, again, what I can do is, I can separate them also into two things. First thing is fresh frozen plasma and second thing is platelet, right? How difficult it is not at all difficult. Blood को हमने पहले लिया, RBCs को अलग किया, then again platelets को भी अलग कर दिया, right? So that's how it works. Now how it looks like, it is going to look something like this. The platelet rich plasma is going to look something like this yellow color, okay? Now, coming to the blood bag components and the buffers. So tell me, what are the blood bag components and what are the buffers that we are going to use? First thing first, we are going to use NaCl because it is isotonic. Again, if I ask you what composition will be isotonic, 0.9%. So that's why we add 0.9% of the NaCl or the acids, depending on what acid we are using, to maintain the pH. Okay, and isotonicity is maintained by specifically 0.9% of the NaCl. If we use citrate, what the citrate is going to do? Citrate is going to bind to the calcium. So it locks the calcium, and unless and until the calcium is there, the blood won't get coagulated or the clot will not form. That's what we want. We do not want the blood to coagulate without any reason in the blood bag itself without transferring it to the another recipient. So it is going to bind to the calcium and it acts as the anticoagulant. So it acts as anticoagulant. Citrate is going to bind to the calcium, and without the calcium, if there is no free calcium available, the platelets cannot bind, they cannot clot together. Coming to the phosphate, we all know, you must have learned in the kidney system, renal system also, that the phosphate acts as the buffer. So over here in the blood bag also we add phosphate. We add the combination of some of the few things over here that we are going to learn, and that also act as a buffer. Can you tell me what is the clotting factor? Yes, 4. True that, right? So phosphate, and can you tell me what is the role of glucose or dextrose? Obviously, everywhere it is acting as the energy source. So in the blood bag also it will be acting as the energy. For the extra energy, we can use adenine. You must have learned the ATP is the source of energy. What is ATP? Adenosine triphosphate. अगर हमने triphosphate हटा दिया, so it is going to be the adenine itself. So it acts as the extra energy, and then the mannitol we use to prevent the hydrolysis. So that is going to be used over here. Now coming to the shelf life, we are going to use the combination of different buffers. That is, first of all, we are going to use the 3 alphabet structures, that is A, adenine, C, citrate and dextrose combination, or CPD combination, that is citrate, phosphate, dextrose. Can you tell me how much is going to be? Yes, Shabazz, I'm getting your comments a bit late, so I'm moving ahead, right? So can you tell me what is the lifespan of ACD? What is the lifespan of SAGM? What is the lifespan of other things? Yes. I hope the comments will come. So I'm going to move on forward. That is ACD and CPD. It is going to contain only 3 alphabets. So remember, least lifespan, that is 21 days. What if I use the next thing, that is CPDA? CPDA, in that we do have 4 different alphabets. So definitely it is going to be more than 21 days. And in the CPD, we do have citrate, phosphate, dextrose. With that, we added the adenine also. So it is going to form it is going to increase the lifespan of the RBCs, or it is going to increase the viability of the blood bag components to the 35 days. But I have the best one, but little expensive. That is, if I use sucrose, adenine, and the SAGM, saline. This S is for saline, adenine, glucose. Rather than dextrose, I use glucose, and mannitol, then it is going to be 42 days, which is going to be maximum. Usually they ask about CPDA or SAGM, right? SAGM is a bit expensive, so most of the blood bank, they use the CPDA itself. Okay, so what is the lifespan? Sanjeev, I got the answer right. Roy, Sonu, Shabaz, yes. So let's move on. RBC and whole blood, if I talk about them, it is going to, obviously depending on what type of buffer we are using, depending on that, they will be having the lifespan of 21 to 42 days. So easy. Then what is the indication if somebody had road traffic accident and the hemorrhage, acute blood loss will be there. In that acute blood loss, we have to give the blood. Then the severe anemia, you must have known the anemia ka grading. Anyhow, we are going to learn that. And higher chances of hypersensitivity if you give the RBCs and whole blood, because we do not know what type of other antigens are present in the blood. Or the 190 days, किसने बोला यार 190 days? No, 190 days तो यार normal में भी नहीं होती, बाहर निकालने के बाद 190 कहाँ से होगा? Yes. Shabaz, did you research some other different kind of shelf life or different kind of RBCs? Please let me know also. Okay. So yes, so that's why we are going to, if it is not required, we prefer giving platelet-rich plasma. Let's say there is an acute blood loss, we have to give the blood. There is no option, but definitely if someone is having hemophilia or petechia-like conditions, we give plasma. Okay. So if I have to do platelet transfusion, then there are two types of transfusion possible over here, single donor and the random donor. Now, single donor means I'm going to take the sample from one donor itself, and this is known as a jumbo pack. Now, you guys tell me, if I add like 2 to 3 donors ke platelet into one bag, they will be containing more antigen. So definitely, who is more dangerous, the single donor platelet or random donor platelet? Who is going to be more dangerous? Line watch. RBCs, right? Chalo. Let's move on. 1 unit contain, that is going to increase the platelet by 30 to 50,000. And in which disease, especially there is one, you must have gone through also that a mosquito causes one disease in which, yes, Shabazz. So the mosquito causes one disease in which we can give the platelets, if the platelets are less than 20,000. Yes, random is going to be much more harmful. Deepak, Shabazz, Sonu, yes. So that's why we choose this single donor, but it is going to be pretty expensive. Not all the patients can afford that. So that's why we have to go towards the random donor platelet. Okay. Patient मरने से बच जाए, यही हमारे लिए काफी है, right? So lifespan is going to be 5 to 7 days. It is almost similar to that in the random donor platelet also. 1 unit platelet is going to only increase the platelets by 10K, and that's why it is not very effective, but at least it will save the life. It is better than, something is better than nothing. So that's how we are going to work, right? If the patient cannot afford it, give him the random donor platelet rather than sending him back, right? It's a dengue. Yes, Mandola, Lone Bilal, Sonu, KK, Ramesh, yes, all of you are right. Okay, coming to the cryoprecipitate and FFP. So, cryoprecipitate and FFP. Cryo means cold and frozen. Both of them are in the negative temperatures. They will be frozen or cryo, right? So, there is therapy also, cryotherapy, in which the patient will be literally crying because they give you literally a -18 degree ka therapy. So that's why the patient will be crying in that. So cryoprecipitate, in that we are going to have, again, this is related to the platelet-rich plasma itself. So we do have fibrinogen. What is the factor? Fibrinogen. First factor is going to be fibrinogen. F for first, F for fibrinogen. Then there is factor number 8 and VWF, that is von Willebrand factor. Please remember, they are husband and wife, okay? If you want girlfriend and boyfriend, you can say that because their relationship is very, very close. Okay. And with that, it contains the factor number 13 also. In the case of FFP, we are going to have fibrinogen and other clotting factor, mainly the fibrinogen. So how to remember? This is the main thing which is there in the FFP. Yes, the cryoprecipitate is going to be better because it contains VWF also, which is not a clotting factor per se. It is released by the endothelial cells. Okay, mainly by the endothelial cells and somewhat in the platelets also. So it is going to be better. Cryoprecipitate is going to be better, and that's why in the different condition, if you have option cryoprecipitate, go for it. If you do not have the option, go for the fresh flows in plasma. A, fibrinogenemia. A, if it is coming in the prefix, that means absence. And I told you yesterday that emia means blood. So A, fibrinogenemia, that means that is going to be the absence of fibrin in the blood. So if you are absence in the blood, so give that fibrinogen, especially with the cryoprecipitate or FFP, because FF is denoting F, that is coming in the fibrinogen also. So in that condition, we can give that. And in the warfarin toxicity, it is going to inhibit the platelet clotting. So you have to give the platelet from outside. Okay. And in the hemophilia A, I'll ask you hemophilia A, B and C. Please tell me what are the factors which are deficient. In the hemophilia A, B and C, deficiency of what factors are there in the hemophilia? Okay, tell me, hemophilia mein what is deficient? Von Willebrand factor. Right, Mukesh, Roy, Sonu. So, please remember that the hemophilia 8 is the A, right? So if you make this is not B per se, it is the 8th, A and 8th. Okay, so sound similar. So please remember hemophilia A, 8, A, 8, right? You are going to tell me about B and C, and till that time I'll move forward. Von Willebrand disease, in that von Willebrand factor will be deficient, and comes the factor number 13. Because it contains factor number 13, if there is a deficiency of factor number 13, we have to give cryoprecipitate, which is not going to be there in the FFP. Okay, so that's why we choose or we prefer cryoprecipitate. Yes, 9. Osama, change your answer a bit. Aryan, you are correct. Roy, yes, only one answer you gave me. KK, Bilal, yes. So you guys are rocking that. It is 9 and 11. Okay, A, B, C, please remember A is 8, B is 9 and C is 11. So rather than making having any confusion, if you reverse that B, it will become 9 and C is 11. Something you at least have to remember. Okay, don't say 10, it is not 10, it is 11. Now let's move on to the storage time and what is their shelf life. Again, whole blood if you give with the RBCs, then it is going to be storing at 4-degree temperature, that is 2 to 6 degree. That is a range which can be given. And acute blood loss may trauma, surgery, severe anemia, in that cases you can give it. So there are two conditions, that is acute blood loss and severe anemia. Everybody should know about it. And just now we talked about it, that depending on which buffer and the clotting, anti-clotting factors you are using, depending on that, the shelf life is going to be 21 to 42 days. है ना, just double करना है आपको. The volume is usually 350 ml. Why? Because the bag contains 350 ml का capacity. Then comes the random donor and single donor platelet. They are stored at room temperature. So please remember, platelets are stored at room temperature, and usually room temperature is 24 degrees Celsius, and that's why the platelet requires, otherwise in the cold they tend to coagulate. So that's why we do not keep them in the cold temperature. So this is not minus 24, please remember this is 20 to 24. Okay, and obviously we are giving platelet in which condition, you guys already told me, in the dengue and thrombocytopenia. If there is written as penia, it is going to be decrease, and philia, it is filled up, you know, excessively filled up, that is philia. So philia means increase and penia means decrease, and dengue mein it is going to be again decrease. So that's why we give the platelets. Lifespan very less, 5 to 7 days. You can remember it as 1 week. The content of that is going to be less also. 60 to 80 ml, it can be 60 to 80 ml and or 200 ml depending on what type of platelets we are using. Random donor mein it is going to be higher, and single donor mein it is going to be lesser. Talking about cryoprecipitate and FFP, it is stored. The name itself telling you frozen or cryo, that means it should be stored at very, very, very low temperature, that is minus 80 degree. And we talked about their condition just now. It is just summarizing, but since we are keeping it at very, very low temperature, what happens is metabolism inside the plasma is going to be very, very low, and that's why their lifespan actually increases. That is better for us, that till 1 year we can save it. Depending on what type you are using, cryoprecipitate stays for 1 year, and in that we are going to use 10 to 20 ml at a time and 200 ml for the fresh frozen plasma. Alright. चलो जी आगे बढ़ते हैं. No need to be sorry. Do as many mistakes as you want here so that you do not make mistake in the exam. Okay. Warning prior with the body heat, that is going to be 6 to 8 drop per minute. पहले क्या करना होता है हमें? Since we take the blood from -4 degrees Celsius, so we have to warm it up, and body temperature से या body heat से warm करो, and start it with the 6 to 8 drop, but then onwards we are going to increase the speed if required. But कितना speed increase करेंगे? Can you guess? Till what you can increase the speed? Yes, please, answers. XLR, XLR, AR, right. Deepak, nice. Chalo. So we can increase the speed till 10 to 14 drops only, है ना? So याद रखना है तो 6 and 12 you can remember. Okay, 6 over here and then 12. So please remember, we are not going to increase the speed beyond 14 drops per minute. Okay, why? Because it takes time to get that blood into the flow, and that's why if there any reaction occurs, so that we are able to see that reaction earlier, and the rest of the body won't show much of the reaction as we are not giving it in a very high manner. So that's why please remember that if you see any signs, for that matter, any reaction, any allergy sign, or petechia, urticaria, anything you see, or even the patient can have fever, if patient tells you something like that, please do stop the blood transfusion. What is BT over here? It's not the bleeding time, it is the blood transfusion. So we have to immediately stop the blood transfusion. Okay, they are going to give you what will be your next step. And in the option D, they are going to give you stop the BT. And in the first option, they are going to give epinephrine, give Avil, give steroids, right? And in the D option, they are going to give you the option like stop BT. So please read up all the options and please mark stop BT if it is there in the option. If not, if somewhat reaction is there and already you have given all the blood, so definitely you cannot take out the blood, right? So what you are going to give? You are going to give Avil, that is phenyramine, and you can give the dexamethasone also. Now, if you have given the blood, after that, after some hours, if the patient is showing some signs, definitely it may lead to anaphylactic, because allergy is happening and it is in the blood. So it may lead to anaphylactic shock, and that may cause the hypotension. Yesterday only, when we were learning about the eosinophil and basophil, histaminase, I told you histamine causes vasodilation. So it is going to be distributive shock, which is possible in the anaphylactic reaction also, and that's why the patient may have the hypotension, because less blood is there which is coming towards the heart, and that's why the patient will land up into the hypotension. For that, to cure that, what you're going to give? IV Dexa, IV Avil, right? So no. So what you're going to give for the treatment of the hypotension or anaphylactic shock? You have to raise the tension, that means you have to raise the BP, otherwise your brain is not going to, why yours? The patient's brain is not going to get the perfusion, he will be unconscious within minutes. So you have to raise the BP. Hypotension is much more dangerous as compared to the hypertension. Please remember that. As hypoglycemia is worse as compared to the hyperglycemia. Hyperglycemia में तो पता भी नहीं चलता है ना? But in the hypoglycemia, the patient will fall unconscious within minutes. Yes, you guys are rocking. Again, I don't know the musical notes. Then Arefa, Deepak, yeah, you guys are right. So we have to activate the sympathetic system, and I am sure that sir have taught you the sympathetic system. In that we do have epinephrine, which is released from the adrenal gland. If we are giving that from outside, we call it as adrenaline. You can say epinephrine or adrenaline, one and the same thing. Okay. Complication. What can be the complication? Most common complication is going to be fever. The patient will be having raised temperature, that is going to be fever. Hypothermia can be there because if you give the blood without warming it up, definitely the patient will be having chills. That is hypothermia. Hyperkalemia. Why? Because understand, the cells contains a lot of potassium. Sir must have taught you in the RMP that cell is the bag of potassium. So it contains a lot of potassium. When you are going to give it, some of the RBC may break away while transfusion. As soon as they come into flow, some may break down and they release potassium, definitely. And in the plasma also it contains potassium. So patient might be suffering from hyperkalemia, can be hypokalemia also. It is known as current injury. Now, metabolic acidosis can be possible because we are adding the acids in the buffer, right? And then anaphylactic shock, allergies can be there. Hemoglobinemia and hemoglobinuria. I told you emia means blood. Some of the RBC may rupture while you are giving the blood. So that's why, obviously, किसका सिंदूर लगाया है RBC ने? Hemoglobin का. So if they rupture, the hemoglobin is going to come into the patient's blood. That is called as hemoglobinemia. Emia means blood. Hemoglobinuria, that hemoglobin can travel along the blood, go to the kidney. From there, it gets filtered. It can come into the urine also. That is hemoglobinuria. Okay. Now, let's discuss massive blood transfusion. What do you mean by massive blood transfusion? Yes, RBCs break away into the plasma. Dr. Sonu, you cannot call the senior resident in the exam, okay? So in the exam, what you have to mark, that I'm telling you over here. Yes, you have to call the senior resident, but in the exam, you cannot do that, unfortunately. Right? Chalo, tell me, what do you mean by massive blood transfusion? If you replace full amount of blood volume in 24 hours or half of the amount into the 4 hours. I don't know how they calculate while making the guidelines, but yeah, that is what it is, है ना? NB वालों का ये जो भी WHO वालों का calculation यहाँ से जाता है, right? So half in 4 hours and fully 24 hours. So this is known as massive blood transfusion. So please remember that full में 24 hours, 2 and 4 जोड़ना है, यहाँ पे भी 4 है. So please remember, अगर आप पूरी body का blood आप transfuse कर देते हो, 5 liters blood in 24 hours, 2.5 liter blood in 4 hours. That is going to be more than 10 units. Yes. But कितने टाइम में, ये भी आपको बताना पड़ेगा बिलाल. Then TRALI. What is TRALI? TRALI is transfusion related acute lung injury. That is TRALI. That is nothing but the ARDS. What happens over here is that suppose some of the blood, it goes and it clogs or it causes any sort of allergic reaction. Definitely it is going to cause the dyspnea in the patient and it will cause the ARDS, that is non-cardiogenic pulmonary edema also it may induce, right? So that is why, because of the pulmonary itself or because of the transfusion this is occurring, there is no per se cardiac any abnormality is there. So that is why it is known as non-cardiac pulmonary edema also. Why? Because again, it will raise the, what we say, it will raise the hydrostatic pressure. Since you are giving the massive blood transfusion, what is going to happen? The plasma volume will increase. If the plasma volume increases, hydrostatic pressure increases. Hydrostatic pressure increases, the capillary fluid will leak out. And in the pulmonary area, the capillaries are weak and the heart is pumping the blood towards the pulmonary. So because of increase in the hydrostatic pressure, the blood will move out of the capillary into the interstitium. We call it as edema, which is more common in the lung. Yes, in the another area also it may occur, but the patient won't be giving you the symptoms right away. If he is having dyspnea, definitely he will be telling you that I am not able to breathe right now. Okay, and that's why it is important. Yes, the edema may occur other places also, but it is important what the patient will come to us with the symptoms, right? So he may have bilateral whiteouts also. And then comes the tacho, because air gives the, what is this whiteout? Because air gives the black color on the X-ray, right? If you do the X-ray, since the edema fluid is there, fluid gives the white color, and that's why this is known as bilateral whiteout. Okay, coming to the tacho, है ना? Not the Taco Bell. This is the tacho of the blood transfusion. This is transfusion associated cardiac overload. Obviously, you are giving massive blood, and that's why it is going to cause massive overload, right? एक ही दिन में अगर मैं आपको हिमैट भी पढ़ा दूँ, मैं आपको फिजियो भी पढ़ा दूँ, है ना, मैं आपको मेडिसिन भी पढ़ा दूँ कि ये सब पढ़ना है, then that will be overload on your brain. So similarly, if you give massive blood transfusion, it is going to be the overload on the heart. So that is known as cardiac overload. So that is tacho. And this is going to be cardiogenic, right? So this is something that you must know, and there are facts because the WHO gives the guideline, right? And I feel it a bit boring, but that part is over now. Now comes the interesting part where the concept lies. Okay, so blood is red, cyanosis is blue. I get tachycardia when I think of you, है ना? So if you want to propose someone, please propose like this. And girls, please, if you get the proposal like मेरा दिल बहुत बड़ा है ये वो, so please ask him to go and get the echo done, right? If you say something like that, right, मेरे दिल में बहुत प्यार है, प्यार won't get developed by the heart. We know that it is developed from the limbic system, right? So right away reject them. Okay, let's move on. I told you yesterday that yes, it's possible. Definitely it is possible. Okay, so yesterday we discussed this, that the multipotent stem cell is there. Please tell me the CD markers. I told you the CD markers. Please tell me the CD markers. Common myeloid. I told you myeloid का CD markers क्या होगा बच्चों? And then I told you myeloid and lymphoid. Myeloid से सारे cell बनेंगे except the lymphocyte. Lymphoid से सिर्फ lymphocyte are going to form and natural killer cell. But then again we don't talk about natural killer cell, right? Someone is best if you do not have anyone. Right? So please focus on the medicine. Cardiomegaly, right? So yes, I got the answers. 33 is for myeloid. Please tell for the HSC that I told you yesterday. I told you that the CD 117, that is for, or CD even 34. So 117 and 34, they are for c-KIT gene. It is c-KIT, right? 117 is c-KIT. And CD34 was for the HSC stem cell के लिए, right? And M is, if you tilt the M, it is going to be looking like a 33. So please remember, myeloid के लिए 33, it is going to form all other cell except the lymphocyte and natural killer cells. So yes, we are going to get the RBCs from the myeloid again, right? Okay, let's move on. We talked about the WBC. The major part is over. Again, this you should know. If you want to know, first of all comes the blast cell. Always, whatever you take, whether it is lymphocyte or the myeloid, any myelocytes, right? So that is going to be, the blast cells are going to come first. Same here in the RBCs also. Pro-erythroblast will come first. Then comes the basophilic. It's not a basophil. Basophilic erythroblast, polychromatophilic erythroblast, and orthochromatophilic. So please remember, we used to remember there is a course which is known as BPO, that is biomedical and prosthodontics, right? So BPO is the course. So we used to remember like BPO, that is basophilic, polychromatic and orthochromatic, है ना. पहले क्या होता है, basophilic, we are pretty neutral, then medicine comes in our life, है ना, the life becomes a little bit rangeen, but then we have to study the whole medicine and then it becomes orthochromatic, है ना. So we only study, we don't do anything else unless and until we clear the exam. So this is how the RPCs work, right? First of all, थोड़ा बहुत color होता है बीच में, but that also goes. So over here, both the acidic and basic stain will be picked up, and that's why it is known as polychromatic. यहाँ पे सिर्फ basophilic stain picked up होता है और यहाँ पे eosinophilic या acidic stain picked up होता है, which is known as orthochromatic. Okay, now see over here, yesterday I asked you what is the precursor of platelet. You guys told me I don't know what, but it was the megakaryocyte. So same over here, if I ask you what is the precursor of the erythrocyte, it is going to be reticulocyte. Now what you can see, first thing, as you are going down, first of all, the size of the RBC is going to decrease. The nucleus ka size is going to decrease, and you can see at the reticulocyte there is no nucleus, but something thread-like structures which are present. So please remember, R for reticulocyte, R for RNA, but it is not a complete RNA. It is the remnants of RNA and the remnants of ribosomes also. So there are two RRs which are going to be present over here, the RNA ribosome. So RNA remnants are going to be there and ribosome. So RRR, it's not a movie, it's the reticulocyte, RNA and ribosome. If someone asks you, did you see RRR? So you are going to say yes, it is the reticulocyte containing remnant of RNA and ribosome, that is RRR for me, right? I hope there was some movie, I don't know whether it is there or not, but so please remember, reticulocyte is going to contain the remnants of RNA. It is not a proper RNA, but RBC, as I told you, it is going to contain only and only hemoglobin, right? So unconditional, undivided love only for the hemoglobin. So RBC में कुछ नहीं होता सिवाय hemoglobin के. So please remember, it is going to contain the hemoglobin. Now, when this hemoglobin will start appear, if you see, if you take the bone marrow and if you try to check that where this hemoglobin appears, then definitely it is going to appear in the intermediate normoblast. Now, the same thing is here, BPO. The basophilic erythroblast is also known as early normoblast. Intermediate normoblast is nothing but polychromatic erythroblast, and late normoblast is nothing but the orthochromatic erythroblast. It is one and the same thing, it's just that different names are given, है ना. जैसे आपका नाम होता है, कोई आपको प्यार से बुलाता होगा बाबू, शोना, I don't know what it is, and then if you go to the girls gang, then they have a pretty name, good names, right? And then if you go to the boys gang, then if I pick up the call of my brother mistakenly, they start the phone call with the abusing word, and they never start the phone with the hello. They will always start with some gali or something like that. So I do not do that mistake ever again, right? So you should not pick up the brothers, or any male is present, you should not pick up the call of theirs, right? If you do not want to be mistaken and you do not want your brother's name to be, listen in that abusive language. So whatever it is. So same names, nicknames are given, same things, right? Reticulocyte mein we learn that whatever I told you, that is only important. यहाँ पे nuclear appear होता है, but the only one thing that you need to know that the intermediate normoblast में the hemoglobin is going to appear and nucleus disappears in the late normoblast. I told you, as soon as we get to know that we have to study, then सारे रंग उड़ जाते हैं कब? In the orthochromatic, right? So that is what happens. The nucleus will go, the enjoyment goes away from our life, है ना? Okay, so I'm not going to compare. My friends do not give that, है ना? What my experience, I'm just telling you, might be true. I cannot deny that. ठीक है? Chalo, let's talk about the RBC. There is something known as aplastic crisis. Okay, what is shown over here? Parvovirus B19, right? So uh, yeah, parvovirus B19, what it is going to do? It is mainly going to affect the progenitor cells of the RBC. So it attacks on the RBCs. Why? Because they are maximum in number. So definitely most of the RNAs and everything. Why not the RBCs and the progenitors of RBC? Because RBC does not contain any RNA, DNA, which is required for the reverse transcription in the B19 virus. Otherwise, how it is going to proliferate? It requires those nucleic acids, which is not there in the RBC. So please remember, precursors will be affected, है ना, and not in the right. Focus on the studies, not in the proper developed RBCs. Okay, so parvovirus B19, please remember that. And if that is going to affect the HSC, the RBCs won't get developed, because again the B19 will be taking up all the nutrients from there, nucleic acid from them. So RBCs won't able to proliferate. So that will lead to the aplastic crisis. Plastic means moldable, or the one which can proliferate in the language of bone marrow. Aplastic means absence of that plasticity. It won't be able to proliferate. Obviously, if it is not able to produce more cells, the cell won't come in the blood. So we are talking about the bone marrow over here. It goes in the bone marrow, affect the progenitor cells. The progenitor cells cannot form the RBCs. If the RBCs are not formed, it is called as aplastic crisis. If the anemia is there, we call it as aplastic anemia. Okay, so it is not proliferating or it is not moldable. Okay, चलो जी आगे बढ़ते हैं. Hemoglobin. Can you tell me what is the normal level of hemoglobin overall? Then we will be talking about females में कितना होता है और males में कितना होता है, right? So I'm going to tell you the normal level, that is 12 to 18 gram %. इसको आप ग्राम पर डेसीलीटर भी लिख सकते हो, इसको आप ग्राम पर 100 ml भी लिख सकते हो. It is one and the same thing. Okay, so it is gram per deciliter, gram per cent, gram per 100 ml, one and the same thing. Okay, chalo ji, batao what is the normal level in the male, what is the normal level in the female of the hemoglobin? Tell me, I'm waiting for it. Rutali, you are right. Shabas, right. FMG, neurotoxic. Wow, what a name. And Arefa, right. You guys are more or less right. Chalo, tell me what is the level of the hemoglobin in the female and the male? Sunil, 9 to 12 in what thing? Male में 13, female में 12. Okay. चलो. Osama, yes, right. Mukesh, Bilal, 13.8. कुछ ज़्यादा ही approximate, ज़्यादा ही particular value दे दिया. Okay. चलो. I got more or less the answers. Yes, Shabazz, you're right. So in the male, it is going to be if it is, we call it as 14 to 18. If it is less than 13, if I'm saying 14 is normal, so please remember beyond 14 to 18 is normal level. If it is less than 13, we are going to call the anemia in the males. Why? Because testosterone stimulate erythropoietin, I told you yesterday also, and erythropoietin is higher, the RBCs will be higher, the hemoglobin will be higher, right? On the other hand, in the females, we do have estrogens. And the estrogen, what it is going to do? It is going to inhibit the erythropoietin. If I ask why the females are going to have less hemoglobin, usually females or any student says that it is the menstrual cycle. No, that is not the main reason. Yes, can be the reason, but again, it happens only for the 5 days, not whole month. So please remember that whatever loss of the RBC occurs, that is taken care of, but main reason is estrogen. Estrogen inhibit the erythropoietin, and if the erythropoietin is inhibited, the RBC won't form, and that's why we have less hemoglobin. And how much? Around 12 to 16, right? So 12 to 16, we say that gram % should be the hemoglobin. If it is less than 12, we call it as anemia. But usually in the India, we do have vegetarian diet, which is preferred till now also, and that's why we do have less iron, and that means less hemoglobin will be there. And if you do have less than 11 gram percent in India, it is called as the anemia. In the pregnant female in India, it is less than 10 gram percent, which you must have read in the gynae also. Most common anemia and most common anemia in the female. Please let me know what is the most common. Osama, again I told you the reason. Menstrual cycle, it is not per se a reason. It is kind of you can say it is not even the hemorrhage. Understand, only 80 to 100 ml will be lost in whole 5 days. So you cannot even say that it is, you know, even not even 1% or 0.01% of the blood, whole blood, right? So neonates mein it is much higher. It is around 20 to 22 gram percent. It may go up to 24 also. So you can write, in some books it is written as 24. So I'm going to give the range as 20 to 24% in the neonates. It is pretty high because again they are coming from the relative hypoxic condition outside. So erythropoietin will be high and IDA. Yes, you guys are absolutely right. The anemia, most common anemia is iron deficiency anemia. Again, I told you the reason over here, because most of us prefer the vegetarian diet. In that, whatever iron is there, it is very less. And even if you take the spinach every day, but the iron that is there, that is not organic iron, or we can say that is not absorbable iron. So the less percentage will be absorbed, and that's why the patient will be having the anemia, which is iron deficiency. If the iron deficiency is not there in the option, which will be followed by folate. Folate is which vitamin? It is vitamin B9. Okay, so B9 deficiency is going to be there. Yes, Sonu, you're right. Bilal, Samvan, Aryan, FMG, Arefa, Rutali, all are right. Purnima, Osama, right, you guys are rocking. So what are the common symptoms, obviously, which we do have usually after 12 hours of class, right? Fatigue, weakness, claudication, decrease in the BP, increase in the heart rate just before the exam. That happens with us also. But we don't have anemia, we have some other reason over here, right? So hamare sare symptoms is anemia symptoms. Let's move on. There is one classification which is known as Winthrop's classification. Depending on size and the color, you give the classification that is known as Winthrop's classification. हमने 3/2 का table बनाया. And remember, hyperchromic. Chroma का मतलब होता है color. The chroma itself means color. Right. So if you have anemia, hyperchromatic cannot be possible because hemoglobin is less, and hemoglobin is the pigment which is giving the color. So hemoglobin is less, hyperchromatic cannot be possible. Right. So that is the reason we did not make 3/3 ka table. So please remember that normochromic, normocytic. Anemia mein you do have acute hemorrhage, hemolytic, aplastic anemia. That is pretty normal. The RBC is not per se a problem. The production of RBC or the loss of the RBCs, that is the problem. The RBC per se, it is not having deficiency of any vitamin, or it is not having per se a shape difference or vitamin deficiency, anything like that. Hypochromatic, on the other hand, it is going to be chronic hemorrhage. If chronically it is happening, definitely the body won't be able to have that much of the globin available. So it cannot make, the iron store will be lost also. So it cannot make a proper hemoglobin, which contains iron as well as the protein part, that is globin. So definitely the color will be less if the pigment hemoglobin will be less. Then comes the macrocytic. It is going to be mega. Mega and macro means the same, that is a big cell size. Okay. Blastic, why? Because the blasts are going to be there. So that's why it is known as megaloblastic. Can you give me the example of megaloblastic anemia, guys? Please give me the example of megaloblastic anemia. Yesterday when we were discussing the hypersegmented RBCs, we discussed the megaloblastic anemia mein, which is going to come. Right. Osama, Mandola, Bilal, yes, Purnima. So microcytic mein, they are not going to ask you normochromic. Definitely they will be asking you this chart, and for that we do have a mnemonic. I guess I do have next slide in which it is written, that is CETA, that is sideroblastic, IDA, T for thalassemia, and anemia of chronic disease, that is going to be there. You guys are awesome. Osama, Mandola, Yogi, Mukesh, Shabaz, Yahya, and Yogi again, Arefa, Yes, Sonu, neurotoxic, everybody is right. You are giving the answers. That is B12 followed by B9. Yes, both of them contains or that comes in the megaloblastic wala anemia. Okay, so let's move on. If I have to give you the reasons depending on the ये क्या है MCV? What is this? This is mean corpuscular volume. So how much volume is there in one RBC? Right, so that is going to be mean corpuscular volume, which is basically telling you the size. Okay, so this volume is nothing but the size of mean. That means average RBC size you are checking. If it is less than 80, it is going to be microcytic. 80 to 100, which is going to be normocytic. More than 100, it is going to be macrocytic. And as you guys told me, B12 and B9 is there. Liver and thyroid diseases may have the macrocytic megaloblastic anemias, right? So important is Sita, that is, first of all, we used to talk. Nowadays lead poisoning is also involved, but again lead poisoning will be having many other symptoms which can be seen earlier as compared to the anemia. Anemia hone tak bahut late ho jayega, right? So you can remember Seetal also. It is not Sheetal, it is Seetal. So Sita or L, you can remember sideroblastic anemia, IDA, thalassemia and lead poisoning. Over here, you can remember two things, B19 and B12. Okay, let's start now. Yes, VK vlogs, Preksha, Purnima, yes, folic acid also. Mukesh, chalo, intrinsic factor ki baad mein baat karenge. Now, normocytic, normochromic, I told you there is no deficiency per se of any vitamin or any iron or any pigment, right? What is the problem over here? There are two main reasons. Either the production is much less, or the loss is higher, or the destruction is higher. So production is less and the destruction is higher. Where it can be seen? First thing first, destruction के बारे में हम बाद में बात करेंगे. Till now, just remember, destruction of blood per se. Blood में सबसे ज़्यादा क्या है? What is the most common thing or the most abundant thing in the blood? That is going to be RBCs. As if you compare the cellular component, the RBC is going to be the maximum, and if you are causing the lysis or destruction of it, it will be called as hemolysis, right? So hemolytic anemia will be there. Then comes the CKD. Why? Can you tell me why the CKD will be having the less of the production? Why not the other diseases? Why I mentioned CKD? Because again, you will be getting ward full of patients every time in the government setup per se of the CKD, है ना? PP के सब अपना liver and kidney सड़ा लेते हैं, ठीक है? So same thing is going to happen, and you are going to come across a lot of patients. Make sure that you are not becoming one, okay? So become a doctor, not a patient. Yogi, FM, neurotoxic, yeah, change the name. Yes, Osama, I know this is given in the this thing also, right? So yes, Osama, you're right. Yogi, I got the answer that CKD mein kidney is lost. So what are the two sites from where the erythropoietin is produced? First is the kidney, the capillaries, pericapillaries, peritubular capillaries, their interstitial cells are going to make the erythropoietin, and perivenous cells, hepatocytes, they are going to make in the liver also. Maximum, that is 85% of the erythropoietin is going to come from there, and 15% is going to come from the liver. Aplastic and hypoproliferative bone marrow, I told you, it is not moldable or it is not proliferating the RBCs. That is known as A. The proliferation is absent or it is very less. So it is known as aplastic. It is not able to, the bone marrow is not able to make new RBCs. So aplastic or hypoproliferative bone marrow. A means almost absent. Okay, what can be the reason? Sickle cell anemia, parvo B19, just now we saw in the aplastic crisis, don't forget that, and pure red cell aplasia, that means only the red cells are not forming, but other cells such as WBCs, the megakaryocyte, with that the platelets and the lymphocytes, they are produced. Okay, and in the aplastic usually all of the cells will be less. Hyperproliferative bone marrow may be with the RBCs, platelets and the WBCs will also be less, right? And infiltration, or if any tumor is there, definitely yesterday also in the AML, CML, what we said, that anemia will be there, If the WBC is taking up all the nutrition, definitely that is kind of a tumor or malignancy. So that can also lead to the anemia, right? What can be the reasons for destruction? High destruction. What do you mean by UCB? UCB is unconjugated bilirubin. Unconjugated bilirubin, which is going to be what? It is going to be higher. Why? Because when we are going to talk about the destruction of RBC, we'll see how this conjugated, what do you mean by conjugated, what do you mean by unconjugated bilirubin. That is definitely going to increase because hemolysis is higher, hemoglobin is coming out, which is converting into biliverdin, which is going to ultimately convert into bilirubin also. So there are two types: extravascular means outside the vessel, and intravascular, that means inside the vessel. So what can be the reasons? RES. What is RES? This is nothing but the reticuloendothelial system. Reticuloendothelial system, that is going to be the RES, and that contains what thing? All the lymphoreticular organ yesterday that I told you, that is going to come under this reticuloendothelial system. Endothelium means vessels. So outside the vessels they are going to come, and remember that this RES is going to contain all those things that we discussed yesterday, that is lymph node, spleen, liver, all of them are going to come over here. Since they are outside of the vessel, per se we are not talking about the vessels, right? Whatever vessels are going to come inside this RES, definitely outside of that, the red pulp and the white pulp of the spleen, liver and lymph node, they are going to cause this. If the hemolysis is occurring there, that is known as extravascular. Okay, and intravascular mein, these are the reason. Extravascular mein definitely hepatosplenomegaly, because they are containing there, and the hemolysis is occurring. Obviously the lysis part is going to, the debris are going to stay there for long, and that is going to cause the hepatosplenomegaly. Lymphadenopathy can be there because the lymph nodes are involved, so everything is going to get enlarged. Hemoglobin will be much higher in the blood, and that the examples are HS, that is the hereditary spherocytosis, and in the spherocytosis also, in the elliptocytosis, sickle cell anemia, the shape is changing. Basically, if the shape change occurs, that is going to be extravascular. So if you cannot remember in the exam, please remember at least, if shape is changing of the RBC, that is going to be the extravascular cause. Okay, what about the intravascular? Intravascular, hemoglobin binds to haptoglobulin. The haptoglobulin is going to decrease as soon as the intravascular hemolysis is going to occur. LDH is going to increase because again the the LDH, that means low density, LDH is going to increase, right? And the hemoglobin, that is going to increase, and the hemoglobin urea is going to be there. Why? Because the hemoglobin, it is in the blood, coming into the kidney, coming into the urine. PCT metabolizes hemoglobin, and they are going to form something known as hemosiderin urea. And then there are many reasons. If the autoimmune disease is there, if the PNH is there, we are going to learn detail about the PNH. Important hai. Can you tell me why the PNH is there? That is paroxysmal nocturnal hemoglobin urea. Why it is there? Why the paroxysmal nocturnal hemoglobin urea is going to be there? Yes guys, please tell me. Yes, again, सारे enlargement हो जाएंगे. That is one of the reason, right? Over here, haptoglobulin is going to decrease. Why? Because this is the protein which should be free in the blood. But again, many hemoglobins are coming out of the this RBC in the blood. Why? Because the breakdown is occurring over here. Guys, where are you? You are not giving me the answer. And LDH is what? Lactate dehydrogenase enzyme is there. That is going to act more and more. So activity is going to increase. PNH mein what is going to happen? You must have learned of DAF factor, Mirror factor, right? That is going to increase, and that is going to that is actually deficient, and that is going to activate the coagulation or cascade of complement pathway. Let's talk about the breakdown of the RBC, how the breakdown occurs. So suppose this is the blood. What happens is, as soon as it glows in the spleen by any reason, if that occurs, Purnima, yes, I got the reason now. Yes, you're right. So hemoglobin is going to get degraded. As soon as I write that, you're going to give me the answer. Then I'm not going to write it in the exam, okay? So hemoglobin is going to get degraded into two parts. Even if you separate the name, that is going to be heme and globin. Heme is going to contain iron, and as I told you, except the iron, we do have something known as protoporphyrin 9, which is going to convert into biliverdin first, and then the bilirubin with the help of biliverdin oxidase and bilirubin reductase. No need to remember all of this. Just remember that in the spleen itself, the bilirubin will be forming. But remember that we want to excrete the extra level of the hemoglobin or protoporphyrin, which is converted into bilirubin. We do not want this bilirubin to stagnated in our blood, but who is going to excrete it? Only the kidneys can excrete it, but the kidneys can excrete only the water soluble part, and whatever bilirubin is made by this spleen, it is lipid soluble. So this lipid soluble bilirubin should be converted into water soluble one, and that is the function of the liver. So what the liver is going to do is, it is going to take up that UCB, that is the lipid soluble bilirubin, and it is going to convert into conjugated bilirubin. Now what do you mean by conjugation? It is the simple reaction of converting lipid soluble bilirubin into water soluble so that the kidney can excrete it via the urine. सिंपल कॉन्जुगेशन का क्या मतलब है? लिपिड सॉल्युबल से वाटर सॉल्युबल में कन्वर्ट करना है. यस, राज मात्रे, you are right that pigagen is defective. We'll learn in the detail. Yes, CD15 for DAF, CD59 for Merrill. Yes, Purnima, absolutely right. Then bilirubin will be converted into bile. How? After getting converted into conjugated bilirubin, it is going to come into the hepatocytes. They will form the bile, and those bile acids will go towards the gallbladder and helps to store there. And some of the bile can come into the feces via the stercobilin and urobilin also in the urine. And that is why the feces is going to have yellow color, as well as the urine is also going to have yellow color with the help of UDP transferase, right? Let's move on to the globin part, which is the protein. So most of the globin part is stored into the liver and reused again. Okay. Iron also stored and reused. Now let's come to some factual things again. MCH, MCHC, and the reticulocyte count and RDW. Now MCH, what is it? Mean corpuscular hemoglobin. So obviously whatever is coming in the end, you have to make sure that it comes in the numerator, HB upon RBC. What is the normal value? It is around 27 to 33 picogram. What does that mean? How juicy are the RBCs, right? How juicy are the RBCs? That means how much juice. What is the juice? That is the hemoglobin, hai na? So how much hemoglobin is contained into one RBC? Per RBC, how much hemoglobin is there? So usually it cannot be more than 37%. Okay, so usually that is the highest amount, but what is the normal level? That is 27 to 33 picogram. In some books it is written as 35 also, but I have seen in your notes it is written as 33 only. MCHC, now we are seeing the concentration overall in the PCV. If we take the average, that is the concentration, we have to take all the RBCs, that is going to be PCV. Again, it's a concentration. So hemoglobin with the per PCV, how much it is there, the value it is there. Reticulocyte count, it is going to be I told you 0.5 to 2% it is going to be normal. If it is more, when it will be more, that is known as reticulocyte response. And when you see reticulocyte response, whenever you start to treat any patient of anemia, let's say folate deficiency anemia was there or iron deficiency anemia was there, you start giving the patient the iron or folic acid, the patient start recovering. So you want to see whether your treatment is working or not. You are going to call the patient after 2 weeks and you are going to do a follow-up blood checkup. Then you are going to see whether the reticulocyte numbers are increased or not. If your treatment is working, the reticulocyte must be increased, but you know that she is taking the tablets and that's why it is there. So that is known as reticulocyte response. Especially in the anemia treatment, we can see that. Usually it is 2%, more than 2%, then something abnormal is happening. If it is decreased less than 0.5%, then it will be hypoproliferative, because again the reticulocytes are forming RBCs. So if the reticulocytes are not formed, the RBC won't be formed, and that's why it is known as hypoproliferative. If it is increased, that means the lysis is more, so that's why the reticulocytes numbers are increasing. And RDW, that is red cell distribution width, that is going to be 11.5 to 14.5. What do you mean by this RDW, red cell distribution width? That means we are seeing average size. If one red cell is having bigger size, one is having lesser size, that means they are not similar. So there is a change in the one smear itself. That means we haven't changed the blood of the patient, but in one patient itself, with different types of RBCs are seen, and that is known as anisocytosis. So this is known as aniso. An means it is not matching, iso means same, cyto means cell. So anisocytosis, the shape or the cell size is not similar. It is going to increase in the iron deficiency anemia, variation in the size. Yes. गुड मॉर्निंग. मॉर्निंग कहाँ से हो गई यार, अभी इवनिंग चल रहा है. हाँ, अप्रोच. what should be your approach? If the anemic patient comes, you are going to definitely check the hemoglobin first of all, and then you are going to move ahead. RBC counts are less or hemoglobin less or both of them are less, this is called anemia. So basically we are going to check the hemoglobin, and then we are going to move on to the MCV, that is mean corpuscular volume kitna hai, and then we are going to form the peripheral blood smear. There is something known as Menzer index, है ना. Usually bulb नहीं चमकता है exam में, and the formula is asked which of the following and or how you are going to calculate the Menzer index. So please remember, M first आ रहा है, R last में आ रहा है, so MCV upon RBC is going to be the formula for the Menzer index. The name itself telling you that what do you mean by Menzer, right? So please remember MCV upon RBC, that is going to be the Menzer. You are going to be the other things are going to be there, that is the MCHC can be there, or rather than RBC they can give you PCV there, or MCV in the denominator also there. Please remember it's the cell which we are measuring, right? So it cannot be the other things, MCHC and all concentration we cannot measure. So that is going to be there. So MCV upon RBC. Then what is the use of that MCV and RBC? It is going to be if it is less thalassemia में low आता है and IDA में increase हो जाता है. So please remember, usually it is around 12 or 13. So if it is less than 13, then it will be called as thalassemia. More, that means IDA में it is going to increase. So please remember that it is going to be usually more. So rather than giving you the slides of IDA, they can tell you that the Menzer index is more. Which of the following anemia you are suspecting? So if they say it is more, that means it is increased. So please remember that it is going to be IDA. So very important. कॉमेडी शो चल रहा है क्या यार यहाँ पे, है ना, that I should make you smile. Yes, because the topic is somewhat like that, and yes, the fun part will come, don't worry. आने चाहिए, right? चार्जर काम नहीं कर रहा है इसका. Fine. So let's move on to the IDA. So IDA is most common type of anemia and iron transportation. है ना. ऐसे बच्चे जब बीच में आते हैं 1 महीना पहले, जिनको हंसाना चाहिए, ऐसे लगता है लाइफ इनको अभी तक धो के नहीं गई है अच्छे से, है ना. सो चलो लेट्स मूव ऑन टू द iron transportation. How the iron is transported? First of all, see over here carefully that iron will be in the 2 formats. What are the 2 forms? Either ferric or ferrous, है ना. Ferric ic is going to be 3, है ना. And ferrous अगर आता है us, 2 of us, है ना. 3 of us never happens. 2 of us, है ना. 3 लोग कभी फ्रेंड्स नहीं बन सकते, ऐसे they say it as. So us आ रहा है तो 2 and ferric आ रहा है तो 3. Please remember that. Ferric from में होता है हमारा जो भी हम dietary iron लेते हैं, but we need to convert that into ferrous. So please remember there is one thing which is known as reduction. तो एक को reduce करना पड़ेगा, है ना. So एक का काम तमाम करना पड़ेगा, किसी और से मिला के वैसे वाला तमाम नहीं करना है. ओके, सो स्टैंड अप हो नहीं सकता यार, आई एम सिटिंग, राइट. सो कमिंग बैक टू द रिडक्शन. सो एक का काम तमाम करो एंड मेक इट Fe2+, सो इट इज इजियर टू कैरी फॉरवर्ड इन द लाइफ, है ना. तो लव ट्रायंगल नहीं चाहिए हमें, 2 ऑफ अस. सो फेरस बनाना पड़ेगा. सो एक को हटा दो एंड दैट इज गोइंग टू हैपन विद द फेरिक रिडक्टेज. So reductase enzyme is going to be there on the villi of the intestine, and that is going to be the one which is going to convert in from the ferric to ferrous, है ना. बाकी teachers के लिए तो नहीं बोलते हो यार. I saw many of the female teachers which are very very serious, है ना. उन लोगों में तुम लोग नहीं बोलते हो कि कॉमेडी चाहिए, कॉमेडी चाहिए. मेरे में क्यों चाहिए कॉमेडी, है ना. So reductase, so that is going to be there in the villi, है ना. ऑटोमेटिकली नेचुरली होता है रिडक्टेज, है ना. हमारे ग्रुप में भी कोई ना कोई रिडक्टेज एक जरूर होता है. सो 3 तिगाड़ा काम बिगाड़ा. यस संजय, you are making the entertainment in the session. Thank you for that. So DMT1, DMT1 क्या होता है? Dimetallotransferase 1, which is going to transfer it into the intestine. So which is this cell? Enterocyte. Enterocyte में entry देने के लिए who is there? DMT is there. Now remember, it is going to give the entry to the iron into the enterocyte. Now there are 2 types of questions are there. If I ask you the question that which of the following, again the question will come, I won't ask you the question right away. The question will be remaining there. So please pay attention there that Fe2+ will enter. Now this Fe2+, if I do not want to send it into the blood, it is going to store over here with the help of apoferritin. Apoferritin, ferritin है, right? So ferri आ गया, ferrous नहीं आ रहा, RI आ रहा है. So definitely it is going to be 3 Fe3+ form में store होता है. Why? Because Fe2+, it is easier to cross the cell membrane for us, right? So Fe2+ can go back. We do not want our iron, absorbed iron to go back, है ना. पहले बहुत मुश्किल से उसको हटाया था, वो खुद ही दोनों चलेगा बाहर, तो कोई फायदा नहीं ना. There will be no friendship. So that's why we want to maintain our friendship. So we know that that guy is going to bitch about us. So what we do is we add him up again, right? So Fe3+. यहाँ पे oxidase होता है cell में. So that is going to convert that into Fe3+ and we store it. Now there is going to be ferroportin. Again, there is something known as hephaestin which is going to be there on the top of the ferroportin, which is going to convert that Fe3+ into, Fe3+ will be converted back into Fe2+. Again, reductase will be there in the cell that will come out with the help of this ferroportin. Now understand, the Fe2+ comes out, but it can go back into the cell. So this hephaestin will be there on the top of this ferroportin, and what it is going to do? It will make that Fe2+ into Fe3+ again. what is going on 2+3+, वो कभी कभी बंदा आता है कभी कभी चला जाता है ना, अपने मर्जी का मालिक है. Why? Because Fe2+ can cross the membrane and go in the unnecessary places. You know what are the unnecessary places, right? So that can go wherever it is not required. So we want to convert that into Fe3+ so that it cannot cross the cell membrane easily, and with the help of one transporter. And ferrin ट्रांसपोर्ट कर रहा है, जहां पे भी I आ रहा है, प्लीज रिमेंबर जहां पे भी I आता है it is going to be Fe3+. Okay, so this transferrin is going to transport it wherever it is required. Again, ferroportin will be there wherever the transport needs to be occurring there. So the bone marrow macrophages are shown, not required really. So please remember that two things needs to be remembered. Hephaestin actually helping us to take out more hemoglobin from the enterocyte into the blood, and the hepcidin which is going to be there. Right, infamous, right? We'll do him famous, don't worry. Hepcidin, what it is going to do? It inhibits. The hepcidin is type of a protein, and maximum of the proteins are released from the liver. We know our बेचारा liver works for everything, है ना? कुछ answers नहीं समझ में आते हैं और organs दिए हुए हैं तो liver mark कर दो. Most of the time it is going to be right. Most of the time, 60-70% of the time it is going to be right if they are asking about any protein production per se. So again, hepcidin is a protein. What it is going to do? It is going to inhibit the ferroportin. Ferroportin को inhibit कर दिया तो the excessive amount of iron will not be able to come into the blood. Okay, so that is the role of hepcidin. What it is going to do, it makes sure that the iron which is coming into the blood, it is required. If it is not required, it should not come into the blood. Otherwise, again, it will go in the unnecessary places and it will lodge there, है ना? जैसे हम जाते हैं unnecessary places पे and time waste कर देते हैं, right? So that is going to be there. Now, make sure that you remember this thing, that we must have learn about this anemia of chronic diseases. जब भी inflammation होता है and जब भी जब भी inflammation होता है and जब भी chronic diseases होते हैं, what happens? Cytokines are going to be higher. Now what they are doing? They are increasing the hepcidin. Hepcidin decreases the iron in the blood. So that's why we do have the macrocytic anemias. Okay, so that was the reason for it, that the cytokines, whenever the inflammation, infection occurs or the chronic diseases are there, the cytokine levels increase. If they are increased, they increase the hepcidin in order, and hepcidin is going to decrease the iron transport into the blood. If iron is not there, macrocytic anemia, hypochromic macrocytic anemia is going to be there. Fenton reaction, है ना? Fenton reaction, what is going to happen? This is a reaction of the formation of the ROS, that is the reactive oxygen species. There are some reactive oxygen species are there in the comment box also. So same happens over here, like unnecessary people, unnecessary comments are there. So we actually do not want it. Sometimes it is helpful, sometimes not. Most of the time it is not, right? So ROS are going to be there in the blood, and that's why they ask us to eat antioxidant. Yeah, tell me the reason anemia in the case of Indian females. Indian female, it is different because Indian diet is different. Yes, it is less than 10 gram %. Okay, not 11. We take it as 10. अगर 10 भी है तो ठीक है. Okay, चलो next. अगर मैंने बोला कि Fenton reaction, they just ask you what is the, they won't be asking you the reaction per se, but remember that whenever the hydrogen peroxide is going to be there, usually it is reduced with the help of glutathione. We use something known as glutathione. This glutathione is going to convert that into the H2O. Okay. Most of the time it is going to be 2H2O2, it will convert into 2H2O and oxygen will be formed again. Remember, if it is not there, the reactive oxygen species are going to form, and that is going to form Fe3 plus. Free radicals are going to form whenever we are converting the 2 plus form into the 3 plus form. And one more thing that you need to remember, the question came on this, that the ferritin is inversely proportional to the TIBC. Now what is TIBC? Is total iron binding capacity. Let's see how much is your binding capacity to the class. टोटल आयरन बाइंडिंग कैपेसिटी है ना, कल पता नहीं कितने बच्चे एंड तक थे, आई डिडंट सी. सो टोटल आयरन बाइंडिंग कैपेसिटी, यस सोनू इट्स राइट. Total iron binding capacity means how much affinity, how much love, how much attraction it is having to bind to the iron. जितना iron आता है जटाक्सल ले लेते हैं ना. So that is total iron binding capacity. So whatever iron is remaining, if the TIBC is high, that means the love, the attraction, the affinity is going to be higher, right? And if the topic is not interesting, so what happens? The affinity decreases, right? So TIBC is going to decrease. Now understand, if iron is less, है ना, अगर हम किसी को कम भाव देते हैं तो क्या होता है? They try to allure us more and more, है ना? That is how it works. If you give someone more importance, they do not value us, right? So that's how the iron also works. If the iron is less, the TIBC will increase क्योंकि भाव कम मिल रहा है, right? So iron is less, the TIBC will increase. If the iron is more, the TIBC is going to go down, right? So same ways in the life also happens. So that is going to be there. So please remember that ferritin जितना होगा उसके opposite में TIBC होगा. So that's why keep your value with you, right? So let's move on how you can differentiate. Yeah, ego पे ले ली बात है ना. So how you are going to differentiate in the IDA? Please in your notes some MCV is written. MCV is almost less in all the type of anemia. On the basis of MCV we cannot differentiate which type of anemia it is there. It should be transferrin saturation. Okay, percentage transferrin saturation. If the transferrin is saturated, then what is going to happen? Transferrin, I told you that the name itself telling you transporting, it is transporting the ferritin. So what is going to happen? What is going to happen? Obviously saturation is high, then anemia won't occur, rather the hemoglobin is much more, the iron is higher. So if the ferritin is higher, saturation is higher, matlab kya hai? It shows how much is the iron in the blood. So if the iron is higher, definitely the saturation is going to higher. Why? Because whatever iron is available, it is binding to that transferrin. So if you check the transferrin saturation, it is going to be higher. Now please make a note of it that iron deficiency hai to iron to kam hoga. And I told you that in the ACD, that is anemia of chronic disease, or you can write it as anemia of chronic disease, in that cytokines are higher. Cytokines will stimulate the hepcidin. Hepcidin will decrease the entry of the iron into the blood. So iron is going to be less over here. Sideroblastic पे हम आएंगे. Remember, sideroblastic is the anemia, only anemia in which the iron levels are much more, excessively high iron levels. Okay. Let's move on to the ferritin. Ferritin was there. It is the most sensitive. The question is going to be asked, which of the following is the most sensitive marker or most sensitive indicator of the anemia? So that is going to be ferritin. If you want to check any one marker to check the anemia, please check the ferritin. Then ferritin, that means it is telling you the stores, how much stores are there. Apoferritin or ferritin, that is the stores, how much stores are there of the iron. Definitely if the iron deficiency is there, the stores will be less. In this, the stores will be higher. Why? Because anemia of chronic disease is because of the cytokine, and because of that, what happens is hepcidin levels are high. The hepcidin is not allowing the iron to come into the blood circulation, but the iron is still there. So please remember that iron is there. So iron stores are available, but it is not coming into the blood, and that's why the ferritin is going to be higher over here. Okay, and percentage saturation, it is going to be decrease over here, because again iron deficiency is there in the blood. So transferrin present in the blood, So in the blood, if we talk, definitely it is going to be less in the ACD also. And TIBC, I told you, जितना कम आयरन होगा उतना ही ज्यादा भाव मिलेगा, right? If you value them less or if you do not go behind them all the time, then definitely we will have some self-respect, right? So TIBC is going to be higher, that traction is going to be higher. Over here it is going to be low because we know that the stores are going to be there, and it is also low because iron is there in the enterocyte or in the stores, it is available. Now everything will be increased in the sideroblastic. Only one rule, that everything will be increased. Why? Because iron absorption is more in the blood, it is also more. Just that if the irons are more, definitely the TIBC is going to be less. The only thing is less, that is the TIBC. Okay, so you have to remember this chart itself. What are the causes of IDA? I don't need to tell you again and again, right? So yeah, so dietary deficiency हो सकती है, excessive blood loss, requirement is higher. In the physiological condition, it can be pregnancy, and then it comes the milk. Milk reduces the iron reabsorption. So please remember that after 1 year of age, we ask the mother not to feed all the time to the child, because we know that the iron reabsorption decreases by the milk. So that's why it is going to be there, right? And vitamin C increases the reabsorption. C is not always bad, hai na? So there is one syndrome which is known as Plummer-Wilson syndrome, or this is also known as Patterson-Cali syndrome. So please tell me what is the triad from Plummer-Wilson syndrome. Yes, guys, please tell me the triad. There is Virchow triad, which we are going to learn. Then the Plummer-Wilson triad, which we are going to learn. What is the triad over here? Triads are eating up our brain a lot, right? We're going to take a break at around 7:15. So just show some energy till then. Tell me the triad. What is the triad? I'm waiting. I hope you guys will answer this. First is IDA, then there is dysphagia, and then there is a glossitis. Okay, so this is the triad. Okay, so IDA, that is iron deficiency anemia. Dysphagia, why? Because there is a esophageal web. Yes, I got the answers. Dr. Patel, Ashwini, Tanya, Raj, yes, you guys are wonderful. So, yeah, esophageal web and glossitis IDA, you must have learned that in the surgery also. Someone, okay, so it is most common in the female. Again, IDA hai, so most commonly in the female because erythropoietin is less. Now, what are the things which absorb the iron more, and what are the things which are going to absorb the iron less or decrease the iron reabsorption? Vitamin C more important. Heme iron hai to well and good. Heme iron usually found in the animal products. Animal products like the non-veg food basically. Acidic pH important hai. Then reducing agent, and that's why we are worried if someone is taking ranitidine often. So ranitidine is irreversible blocker, but again that is going to reduce the acidity. Okay, and reducing agents are also there, like cysteine and hydrochloroquine. They also have the effect on the iron absorption. Alkaline pH, again ulta, phytates which are going to decrease it. Tannins, tannin किसमें मिलता है बच्चों? Tannin or theophytin is found in the tea. So excessive tea intake can cause the tannin to increase and decrease the iron absorption and IDA, right? There was a meme which was known as, if you take my blood, it will be T positive, hai na? I myself put that meme. I love that because I'm a big fan of a good tea, right? So that is the only addiction I'm having, that I require at least 2 to 3 teas in a day. So tannin is there in the tea, so that can reduce the iron reabsorption, but we have to control it. Sometimes, especially during the exams, so definitely the tea intake increases. And oxalate, that is going to be there. Now tell me, what is this? Tell me, what is this? Sanjay, I think you're reading everyone's comment. He's not in the class. He is only looking at the comment box because he is appreciating everyone's comment. Yeah, tea lover, Shabas. Purnima also. चलो, टेल मी व्हाट इज दिस. फटाफट बताओ क्या है ये. स्पूनिंग क्या होता है? स्पूनिंग मेडिकोज हो ना. स्पूनिंग क्या होता है? कोलिनाइकिया है ना. पटेल, यस यू आर राइट, दिस इज कोलिनाइकिया. व्हाट इज दिस? व्हाट इज द नेक्स्ट वन? यस, समवन, दीपक, पूर्णिमा. पूर्णिमा नाम बताओ बच्चे. स्पूनिंग नहीं बोल सकते आप. यू आर अ मेडिको ना. हरिप्रिया, हरिप्रिया, पिया, राइट. यस, कोलिनाइकिया. Pani lover. Someone is pani lover. Okay, we'll be giving you the water. So cholinachia and chiliosis, that is going to be there. That thing I showed you over here, dryness, and this is a particular lesions which are there near the lips, the dryness of the lips, and this is known as chiliosis, right? तो cholinachia, chiliosis बोल सकते हो, chiliosis बोल सकते हो, whatever you are going to call. Spoon shaped nails, it is the hallmark of the IDA. So please remember, आइडिया आना चाहिए हर चीज का अबाउट द आइडिया, बिकॉज द इंडियन गवर्नमेंट वांट यू टू रिमेंबर एवरीथिंग अबाउट आइडिया, बिकॉज दे वांट यू व्हेन यू आर प्रैक्टिसिंग, दे वांट यू टू not miss the patient of IDA. So definitely one case will be there from the IDA, iron deficiency anemia. I'm not sure what they're going to ask you, pathology or medicine, but definitely one case will be there from the IDA. Okay, so please, at least if you want to remember one thing, one anemia, so it should be IDA. Okay, peripheral smear. Microcytic hypochromic, we saw that. Anisocytosis also we saw. Anisocytosis mein two types of cell we are going to see, that is poikilocytosis also going to be there, and pencil shaped cells will be there. So you can see over here, oval shape, cigar shape, pencil shape, whatever shape you are looking at, right, depending on your interest, है ना. हमारा ये interest नहीं है, so I can see only oval shape or pencil shape, right. पढ़ाकू होगा तो उसको ऐसे दिखेंगे, है ना, किसी को ऐसे दिखेंगे, और जिनका सुट्टा उट्टा मारने का मन करता है उनको शिगार शेप दिखेंगे, है ना. डिपेंडिंग ऑन द साइंटिस्ट this thing interest, they gave the name to these cells, cigar shape, oval shape, yeah, pencil shape. You can see all these types of cell over here. So please remember, if anything mentioned like this, it cannot be any other than the IDA. Okay. Yes, Sonu, they are giving it free, but I don't know, I really doubt the quality of that, right. ओरल ट्रीटमेंट क्या क्या दोगे? पहले स्टेबल पेशेंट है, नॉर्मल फीमेल आई है आपके पास, प्रेग्नेंट नहीं है, कुछ ज्यादा नीड नहीं है, माइल्ड टू मॉडरेट एनीमिया है, यू स्टार्ट विद द ओरल थेरेपी. ओके, एंड नॉर्मल बीपी, हार्ट रेट, एवरीथिंग इज स्टेबल. स्टेबल मतलब HB मोर देन 7 होना चाहिए, दैट इज नथिंग बट द हम बोलते हैं ना 8 to 12, 8 to 11 वी से इट एज माइल्ड एनीमिया, है ना, अगर 7 से ज्यादा होना चाहिए. ओके, 5 to 7 वी कॉल इट एज मॉडरेट एनीमिया. अगर इससे भी कम है, 2 to 5 है, तो दिस इज सिवियर एनीमिया. इन द सिवियर एनीमिया वी हैव टू स्टार्ट विद द ब्लड ट्रांसफ्यूजन. ओके, अपने हिसाब से देख लो. राइट. सो फेरस सल्फेट, फेरस फ्यूमरेट या gluconate and ferrous ascorbate, which whatever you want to give, these are the combinations of drugs which are going to be there, composition of the drugs which will be there. Usually we give it for 3 months. एक trimester तो बनता है, right. IV iron, then it is going to be ferrous sucrose and carboxy maltose. That is the composition which is going to be there in the IV. There is one more condition. If there is diseases, there is one thing, parasitic diseases are there, then what happens? There is a problem in the reabsorption. Okay, so in those also we give the IV iron, because again it is not absorbing properly iron, so definitely we have to give IV. Okay, Dr. Sonu, if HB is less than 7, definitely we have to give the blood directly. Coming to the sideroblastic anemia. Sideroblastic, कौन सा ब्लास्ट है? sideroblast, right. So sideroblast में याद रखना, हीमोग्लोबिन बहुत ज्यादा हो जाता है, so आयरन ओवरलोड हो जाता है. जैसे आप में होता है ना, बहुत सारा चीज पढ़ाने के बाद ब्रेन में ओवरलोड हो जाता है, वैसे ही आयरन ओवरलोड को बोलते हैं sideroblastic, है ना. So please remember, S for sideroblastic, S for saturation. So after some time the saturation is going to come, the messages will come कि break कब मिलेगा, है ना. So same sideroblastic से याद रखना कि sideroblastic में iron overload is there, saturation of iron is going to be increased. So MCV is going to be less, iron is going to be high. MCV क्यों कम है? Iron high है, cell का volume high नहीं है. So cell volume, RBC का volume is not high, and that's why we are calling it as anemia. Though the iron is high, that doesn't mean that the RBC levels are going to be high or they have the higher capacity to carry oxygen. No. Decrease carrying capacity of the oxygen, that is going to be your anemia. And that's why we are going to call anemia, because cell volume is less, serum iron is high, ferritin is high, and obviously MCV कम है, iron ज़्यादा है, आप पीछे पड़े हुए हो तो भाव कम मिलेगा. That means TIBC is going to be decrease. पेरिफेरल स्मीयर में आपको क्या मिलेगा? बेसोफिलिक स्टिपलिंग मिलेंगे, रिंग सिड्रोब्लास्ट. वाओ, हाउ डिफिकल्ट इट इज, है ना. सिड्रोब्लास्टिक एनीमिया में सिड्रोब्लास्ट मिल रहे हैं. ऑब्वियसली दिस इज गोइंग टू बी देयर. पैपेनहाइमर बॉडीज कैन बी देयर एंड माइक्रोसिटिक हाइपोक्रोमिक एनीमिया विल बी देयर. एंड प्राइमरी सेकेंडरी में डिफरेंशिएट कर सकते हो. मोस्टली दे आर नॉट गोइंग टू आस्क. प्राइमरी एटलीस्ट याद रख लो. एला सिंथेस डेफिशिएंसी से अगर होता है, डेफिशिएंसी दैट मीन्स प्राइमरी मीन्स पेशेंट के बॉडी में प्रॉब्लम है, सम जेनेटिक म्यूटेशन हैज बीन देयर, सो दैट्स व्हाई इट इज कॉल्ड एज primary. If you have induced it without anything, or patient got induced it because of some other thing like isoniazid toxicity or lead poisoning, it will be secondary. Again, the same thing is given over here. I'm not going to go over that. Coming to the lead poisoning, please remember lead poisoning हम ABCD से याद रखते थे. ABCD क्या है? Anemia, sideroblastic anemia, it can be there. The symptoms will be similar. B is basophilic stippling again, and Burtonian's lines will be there. Colicky pain, drop, हाथ में होगा तो wrist drop, foot drop में होगा तो that is common peroneal nerve, and encephalopathy will be there. Infertility will be there. Treatment क्या देते हैं? EDTA will be the treatment. Yes, lead poisoning will be there. That's what I'm talking. So let's move on to the AOCD. Everything is given in your notes, so no need to remember that, right? So ABCD, please make a note of it. Yeah, so AOCD, what I told you in AOCD that chronic disease है. Disease में क्या होता है? Cytokine is going to increase. Again, one of the revision. Cytokines high है तो hepcidin will be stimulated. So hepcidin will be higher. If hepcidin will be higher, definitely it is going to inhibit the iron to come out from the cells, so it will be inhibited, so it will remain in the cell, the iron will remain in the cell. Chronic inflammation है, macrophages भी है, और hepcidin is just going to be there, will lock the iron into the store format. MCV will be decreased and can be normal, but iron definitely कम होगा. Why? Because we are talking about the serum iron. Iron कम है तो ferritin बढ़ जाएगा. फेरेटिन का मतलब है स्टोर्स, है ना. सो फेरेटिन यहाँ पे होता है, सेल में होता है. सो फेरेटिन इज गोइंग टू बी हायर. व्हाई? बिकॉज the iron is not able to come out. TIBC is going to be less because the iron is less. Okay, so that is there. And the rheumatoid arthritis में क्या होता है बच्चों? Chronic inflammation, macrocytic hypochromic, one of the example of the same thing. MCV down रहेगा इसका, and most commonly it is going to be nomocytic nomochromic. MCV normal रहेगा, इसीलिए normal बोलते हैं. और इसमें हम मेथोट्रेक्साइड देते हैं, फॉलेट देते हैं अगर हमारा MCV हाई है तो क्या करता है ये? फॉलेट को कम कर देता है. बेसिकली एंटी फॉलेट होता है ना, सो फॉलेट का एब्जॉर्प्शन ये कम कर देता है. सो मेथोट्रेक्साइड जब भी देते हैं, मोस्ट कॉमनली गायनी में आपने बहुत बारी पढ़ा होगा मेथोट्रेक्साइड, तो फॉलेट डेफिशिएंसी हो जाती है, तो साथ साथ में हमें फॉलेट भी देना पड़ता है इसमें. ओके, चलो. सो आई गेस वी कैन टेक अ ब्रेक ओवर हियर. Right, it's a 7 o'clock because I want you guys to be fresh enough when we are reading about the thalassemia, है ना. The types of anemia which we are going to read. Thalassemia, we'll take a break of like 15 minutes, है ना. So we'll take a break of 15 minutes and after that we'll continue with the thalassemia. All right, guys, I hope I'm audible and visible. Let's start once again. I hope you had nice snacks or something like that. Let's start, you know. मेरा वीडियो नहीं आ रहा. All right. So let's start. So break is over. I hope you had snacks and everything. You took your glucose shot, you know. Let's start. Fine. So thalassemia, there are two types of thalassemias, alpha thalassemia and beta thalassemia. Why there are only two types? Thankfully, we do have two types of chain in the hemoglobin. What are the chains of hemoglobin? So hemoglobin, suppose this is like a cab or a van for the oxygen, right? So it is having two types of globin chain, each of them twice. So alpha and beta, they are two types and each of them are going to have two molecules. Welcome back. You welcome back. This is my class. Thank you. So alpha 2 and beta 2, right? So they are the two types of globin chain, and depending on that we do have beta and alpha thalassemia. Alpha thalassemia is less common as compared to the beta thalassemia. Why is it so? Because remember, during the fetal life we do have alpha to gamma 2 chains, that is HBF. So alpha chains are already there. That means the factory of alpha chains are already there. The thing is that after birth, this beta chain, if it is not able to form due to any mutation, then the beta chain won't be formed, and if the defect is in the beta chain, we call it as beta thalassemia. या मेरी क्लास में मुझे वेलकम कर रहे हैं. एनीवेज चलो, सो बीटा में डिफेक्ट है तो बीटा थैलेसीमिया, अल्फा में डिफेक्ट है तो अल्फा थैलेसीमिया, है ना. ब्रेन में डिफेक्ट है तो कुछ नहीं कर सकते. ऑल द थैलेसीमियाज ऑल टुगेदर, राइट. एंड such defect cannot be cured. So 2 alpha 2 beta chain, everybody knows that, and 4 alpha genes are there. So alpha 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 ऐसे gene होते हैं, and if one gene is defective, to form one alpha chain we should have 4 genes. So alpha 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 में एक gene कम है, so that is 75%. It's okay, है ना. Even if the 75% we get the marks of 75%, we'll be more than happy. Yes, but 50% आए, 150 एग्जैक्टली आए तो थोड़ा डर भी लगेगा कि यार फेल भी हो सकते थे, है ना. बट फिर भी काम चल जाता है. माइल्ड सिम्टम्स, ओके, जस्ट लाइक अस. इवन इफ 150 इज देयर, वी आर फेयर इनफ कि यार चलो, बट दिस कैन डिटोरिएट. सो दिस इज टेलिंग यू लाइक अगर TND में अगर 50% आ रहे हैं, सो यू नीड टू स्टडी अ लिटिल हार्डर. व्हाई? बिकॉज अगेन एग्जाम में कुछ भी हो सकता है ना. +-20% ऑलवेज हाथ में लेके चलना चाहिए. बट अगर 25% रिजल्ट आ रहा है TND में, तो प्लीज थोड़ा और दम लगाओ, राइट. सो सीवियर HBH एंड देन 100% डिफेक्टिव है तो बच्चा प्रोड्यूस ही नहीं होता है, बिकॉज अगेन वी आर टॉकिंग अबाउट द अल्फा चेन विच इज रिक्वायर्ड टू हैव इन द फीटल हीमोग्लोबिन ऑल्सो, है ना. तो कुछ भी नहीं मार्क्स आ रहे हैं तो प्रॉब्लम है. TND में नहीं आ रहे मार्क्स, ऐसा होता नहीं है यूजुअली, बट 25% से कम आ रहे हैं तो कोई चांस नहीं है पास होने का, है ना. तुम्हारे दोस्त लोग ऐसे होंगे बिकॉज दे वोंट बी अटेंडिंग द क्लास एनी हाउ. सो दिस विल डाई इन यूट्रो, दे वोंट सर्वाइव इन द एग्जाम ईदर. सो प्लीज रिमेंबर थैलेसीमिया एज द एग्जाम. सो hydrops fetalis will be there and erythroblastosis fetalis is also going to be there. Let's talk about beta thalassemia because again the beta thalassemia is the most common one. Same, अगर आपने बीटा चेन का एग्जाम्पल लिया तो बीटा 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 ऐसे ही आपका चलता रहेगा, राइट. सो बीटा चेन डिफेक्ट माइनर और नो सिम्टम्स, राइट. इंटरमीडिएट माइल्ड टू मॉडरेट सिम्टम्स, एक ब्लड ट्रांसफ्यूजन से हो जाता है एवरी 3 to 6 months, है ना. सो कैसे चलता है कि एवरी 3 hourly अगर आप 10 क्वेश्चन भी सॉल्व करोगे in a day for 30 days or whatever days are remaining, this will be sufficient, है ना. It's kind of a mild to moderate symptom वाला condition, and major है तो every hourly you should solve 10 questions, okay. So that is severe symptom. So please remember every monthly we have to give the BT transfusion in the severe or major cases. Cooley's anemia, this is transfusion dependent because again we have to do the transfusion. right? So what is the thing that you need to remember? Only few things over here. Let's discuss everything. Cooley's anemia, or this is also known as Mediterranean anemia, because it is famous in that region, or it is much common in that region. So occurrence is less common, obviously more common. I told you, if it is less symptom, thankfully that is going to be more common, because we do not want much of the patient, or the nature does not want much of the living beings to die. It wants to help us out if we are maintaining the nature also. So we should work in the harmony. Okay, so usually that happens, जो less severe होता है वो most common होता है, again because survival उनका ज़्यादा है, तो against prevalence भी उसका ज़्यादा होता है, and heterogeneous होता है ये ट्रांसमिशन, दैट मीन्स मदर से भी आ सकता है, फादर से भी आ सकता है, दोनों से अलग अलग आएगा, नॉट द होमोजेनस वन. दिस इज गोइंग टू बी माइल्ड ऑब्वियसली, एंड पार्शियल सिंथेसिस तो होगा ही, कंप्लीट ए सिंथेसिस नहीं हो सकता, एंड नॉर्मल और प्रेजेंट हो सकता है एचबीएफ, राइट? व्हाई? बिकॉज वी आर टॉकिंग अबाउट बीटा थैलेसीमिया, एचबीएफ लेवल्स आर गोइंग टू बी देयर, राइट? प्रेजेंट भी हो सकता है, व्हाई? बिकॉज बीटा थैलेसीमिया partially not there, so that means HbA will not be formed, so HbF will remain there, and lifespan shorter 17 years तक हो सकती है, या longer भी हो सकती है, right? So what things over here to remember? First of all, remember HbF levels are going to be very high in the beta thalassemia or Mediterranean thing, that if they tell you that 3-year child present to you with the HbF, so 1 year में almost HbF गायब हो जाता है, so 99% will be HbAs, okay, in 1 year child. If they are giving you the symptoms of or case of 3-year 4-year child with the HbF, definitely they are pointing you towards the thalassemia. So please make sure that this is going to be there, and obviously they cannot survive after 17 years of life, right? So diagnosis कैसे बनाओगे? MCV देखोगे, that is going to be less, and Menzer index देखोगे, thalassemia में L आ रहा था, right? So thal में L आता है, so please remember it is going to be low. And peripheral smear में देखोगे, thalassemia के features देखेंगे. क्या मिलेगा thalassemia में? Please tell me what you are going to get in the thalassemia. हाँ जी बच्चों, क्या मिलेगा? पेरिफेरल स्मीयर किया मैंने, थैलेसीमिया मुझे कैसे पहचान में आएगा? व्हाट टाइप ऑफ cells I am going to see? कहाँ गए वेलकम करने वाले? चलो बताओ क्या मिलेगा. यस पूर्णिमा, यू आर राइट. राज, ओके. और कौन से सेल्स दिख सकते हैं बच्चे? और कौन से सेल दिख सकते हैं? Preksha, absolutely right बच्चे. So there is going to be teardrop cells, which are also seen in myelofibrosis. Yesterday I told you that they have the problem in the getting out, and as the Raj also told, that is target cells will be there. How they are going to look? The teardrop, है ना, जैसे हमारे आंसू निकलते रहते हैं क्लास अटेंड करते हुए, एंड में आने तक half of the population will go away, right? So it is going to be teardrop like that, है ना. टीचर्स रोते हैं फिर, है ना, not the students, right, कि where the बच्चा parties are. So like that. So teardrop अगर दिखा तो याद रखना thalassemia है, राइट? सो थैलेसीमिया थैलेसीमिया थैलेसीमिया. सो टारगेट सेल, यहाँ पे आप टारगेट सेल देख सकते हो, बुलजाई, राइट? सो बुलजाई लाइक थिंग दैट इज गोइंग टू बी देयर, दैट इज टारगेट सेल. ऐसा कुछ दिखा आपको, सो डेफिनेटली इट इज गोइंग टू बी द टारगेट सेल और the teardrop appearance. अब ये बताओ क्या है? If such kind of patient comes, you cannot miss. And she is very famous, है ना? She is everywhere in the books. She became very famous because she was the only child which had that prominent symptom. So if such question come, you cannot miss this, है ना. जैसे आपको हीरो हीरोइन के या फेसेस याद होते हैं ना, तो वैसे ही इसका फेस आपने भूलना नहीं है, इस लड़की के प्यार में पड़ जाओ, है ना. सो यस, पूर्णिमा गेव द आंसर. सो इट इज लुकिंग लाइक अ चिपमंक. ओके, मूवी में क्यूट लगते हैं बट रियल लाइफ में होते नहीं है, राइट? एंड क्रू कट अपीयरेंस, एज यू गाइस ऑलरेडी टोल्ड मी, somebody told me the crew cut appearance. Bachcho, my audio video is fine. Is it fine? Because I cannot see it. Right. So, crew cut appearance, symptoms inappropriate erythropoiesis, chipmunk face, head on end appearance, yeah, crew cut appearance is going to be there. So, that is going to be there, or it is also known as army cut. चल नहीं रहा है ये, फिर से बंद हो गया. All good. Chalo, I am going to move on. Just make sure if you cannot see something, just tell me, because in my this thing some problem is there. So I cannot see your comments for a few seconds because they took the iPad totally and I was not able to see. But now I won't be able to see your comments also. Hai na? So I told you, na, the second side I showed you, this kind of things happen near me. Hai na? I cannot help it out. Hai na? I just attract those kind of things, I guess, है ना. IOC, investigation of choice क्या करोगे आप? HPLC करोगे. More than the hemoglobin electrophoresis, investigation of choice will be this thing only, HPLC, in which you're going to see, it is double thing, in which you're going to see the chain defect, right? It can be there in the thalassemia also, sickle cell anemia also, and hereditary spherocytosis. तो HPLC तीनों के लिए investigation of choice रहेगा. SCL के लिए अगर SCA हो जाता है तो प्रोटेक्शन अगेंस्ट मलेरिया. नाउ दैट डजंट मीन दैट SCA इज गुड. अगेन मलेरिया बहुत प्रोबेबिलिटी बहुत कम है मलेरिया होने की, है ना. सो अगर कोई बोलता है कि क्या कहते हैं, हाँ, कोई बोलता है दैट SCA हो गया तो कोई बात नहीं, मलेरिया से बच जाएगा, तो मलेरिया की प्रोबेबिलिटी इज वेरी वेरी लेस एज कंपेयर टू द thalassemia. ठीक है. So protection against malaria, it is going to be there, and glutamate will be replaced by valine. So पहले glutamate होना चाहिए, G for good. Please remember, there will be option that the valine is going to get replaced by the glutamate. That won't happen over there. The valine is not good, है ना. Valine is like a vampire. The good thing is changed by a valine. So both the option will be there. The valine is replaced by glutamate, and that will be the option A or B, and the last option will be, or C or D option will be, glutamate is replaced by the valine. Please read carefully. So that is going to be your SCA. Protection malaria के लिए, but हमें SCA नहीं चाहिए. Clinical feature, again same clinical feature. Obviously hemolysis ज़्यादा होगी क्योंकि that is not the normal hemoglobin. So RBC will be broken down, तो bilirubin बढ़ेगा. मेनली कौन सा बिलिरुबिन बढ़ेगा? अनकॉन्जुगेटेड बिलिरुबिन बढ़ेगा, क्योंकि कॉन्जुगेशन की एक लिमिट होती है, एक हद होती है ना. जैसे आप लोगों की भी एक हद होती है कि 8 बजने के बाद ना कुछ दिमाग में नहीं घुसता है ना, या 9 बजने के 10 बजने के बाद ना it blocks everything, है ना. So same limit is there for the liver also. Beyond the limit it cannot conjugate the bilirubin, right? And hand, foot, mouth syndrome is there, in which the bony pain is going to occur and osteomyelitis is going to take place. Please remember one thing only, that the osteomyelitis everywhere, the most common organism is Staph aureus, but over here it is going to be the Salmonella. Salmonella is going to be the most common organism over here, right? It is back again. Glutamate is good. Valine is like a villain or vampire. Again, a dose of tannin is required, है ना? Because the normal hemoglobin is boring. है ना, कुछ abnormality चाहिए हमें, right? So that is there. And please remember, यहाँ पे सलमान भाई करेंगे osteomyelitis, right? So he is there. Then what are the warning signs? Acute chest syndrome is going to be there, because hemolysis हो रही है तो वहाँ पे भी जाके वो clog करेगा. So pain is going to be there. Priapism can be there. Sudden painful erection. Thankfully we are females, right? So sudden painful erection of the penis in the males, because again वहाँ पे जाके अगर क्लॉक कर गया, hemolysis हो रहा है, so वहाँ पे अगर क्लॉक कर गया, so the exit, the venous return will not be happening, and the blood collection is going to take place, and that's why priapism is going to be there. the treatment is going to be the autosplenectomy is going to occur there, and heart failure signs will be there. And what is ATN? Acute tubular necrosis will be there in the kidney. Yes, thank you, Roy. I know that. Right, so diagnosis kya hai? Because since 8 o'clock I was there in the MAMC and I had classes and I was like, my brain is not working, and that's why there was less jokes maybe, that I wanted to have some, energy booster. So that is why there cannot work without tea, because till 4 o'clock I was taking the classes, 2 to 4 also I had class, unfortunately today. फ्राइडे में होती नहीं है यूजुअली वैसे, बट आज मेरी थी BDS की क्लास, देन आई केम हियर अगेन द क्लास, सो needed the tea. MCV normal, but hemoglobin is going to be less. Peripheral smear में आपको सिकल सेल दिखेगा, हम सिकल सेल एनीमिया की बात कर रहे हैं. Why the sickling occur? Basically सिकलिंग में होता क्या है, जिस ध्यान से देखो, कोई पूछेगा नहीं आपको, बट अंडरस्टैंडिंग के लिए इंपॉर्टेंट है. What happens is, suppose this is one hemoglobin, this is another. I'm not drawing the chains of hemoglobin, I'm drawing the hemoglobin. Suppose the hemoglobin is there in the RBC, because that is the only thing the RBC is going to have, है ना. हमारे पास क्या होता है, हमारे पास किसी का प्यार होता है, राइट. इसके पास और कुछ नहीं है, बस हीमोग्लोबिन है. अलग अलग हीमोग्लोबिन है. होता क्या है, in the sickle cell, since the valine is there inside the hemoglobin, what is going to happen, unless and until the oxygen is there, it survive very nicely, है ना. Someone gives you a credit, someone praises you, everything is going good, है ना. जब तक माँ बाप पैसे दे रहे हैं, सब बढ़िया जा रहा है ना. But suddenly what happens? The oxygen leaves it, है ना. Parents बोलते हैं खुद करो जो करना है, right? तो life hits you bad, and then what is going to happen? Then those hemoglobin come together. यूजुअली लड़के लोग साथ में बैठते नहीं है, बट कोई छोड़ के चले जाए तो सारे फ्रेंड्स एक साथ आ जाते हैं. दैट इज हाउ इट इज गोइंग टू हैपन. सो व्हाट हैपेंस, एज सून एज द ऑक्सीजन लीव्स, दैट मीन्स व्हेन द टिश्यू इज गोइंग टू टेक अप द ऑक्सीजन एंड देयर इज डीऑक्सी hemoglobin is there, they start to bind to each other, and these valines are going to make them sticky, or these hemoglobin molecules, they start to precipitate in the RBC, and they are going to form a chain. And that's why, rather than having that spherical structure, the RBC is going to have this half moon shaped structure. Why? Because there is a chain which is forming of hemoglobin, and that is making this structure. Okay, so hemoglobin is going to be there as a chain, and that's why the RBC changed its shape accordingly. So RBC cannot be anymore this circular, it will be sickle shape. And then comes the sickling test, which we do with the help of sodium metabisulfite. Sodium metabisulfite ये करता क्या है, ये polymerization of hemoxylate hemoglobin करता है. तो polymerization अगर easily हो गया, इसका मतलब valine है. अगर polymerization नहीं हुआ, तो that means it is not the sickle cell anemia and we are going in a wrong direction. So diagnosis के लिए this helps us out, क्योंकि ये करता क्या है, अगेन एक्सटर्नली हमने ब्लड लिया तो डीऑक्सी कंडीशन तो हम मेंटेन नहीं कर सकते, बिकॉज एटमॉस्फेयर में ऑक्सीजन है. बट व्हाट वी कैन डू इज वी प्रमोट द पॉलीमराइजेशन. वैलिन होगा तो वो पॉलीमराइज कर जाएगा, राइट. इन्वेस्टिगेशन ऑफ चॉइस इज गोइंग टू बी HPLC अगेन, फॉलोड बाय हीमोग्लोबिन इलेक्ट्रोफोरेसिस. सो यू कैन सी ओवर हियर, this is the abnormal hemoglobin, it formed the chain. You can see over here that जो मैं अभी बोल रही थी, that it formed the chain, एक दूसरे के साथ जुड़ जाते हैं, पार्टी करने लगते हैं ना, कि वो छोड़ के ये हो गया वो हो गया, all these things, है ना. otherwise we do not see each other that ways, है ना, जब आप बड़े हो जाते हो. so ये क्या है कि ये नॉर्मल वाला हीमोग्लोबिन है, they are separate, they are living very happily with the oxygen, with their own lives, है ना. and one thing happens over here, not only the stickiness in the hemoglobin, but the stickiness in the RBCs increase, है ना. so valine क्या है, ये क्या increase करता है, it's like a glue, है ना. so it increases the stickiness in the RBC. problem क्या है यहाँ पे देखो, एक साथ जब ये जुड़ जाते हैं, so the small capillaries are going to get blocked by these sickled adhesive kind of RBCs, and the blood flow won't occur. so इस वाले part में क्या होगा, it is going to be ischemic, and that is going to cause the problem depending on where it is causing the ischemia. यहाँ पे ischemia हो गया तो it is going to cause stroke. दिल पर हो गया तो obviously definitely if it it is happening in the heart, MI will be there, and depending on other things, it is going to cause bone में हो गया तो bony pains will be there, all these things will be there. Identify करो क्या है. This is the sickle cells. Okay, क्या देते हैं? Blood transfusion, easy way out because it's a genetic condition. We cannot help them out, and we ask them to not go in the heavy exercises, not do the heavy exercises because that is going to create the deoxy condition. जैसे deoxy condition होगी, that is going to worsen up. And मैंने एक ड्रग आपको कल भी बताया था, हाइड्रोक्सी यूरिया. What it does is it leads to the conversion of HbA into HbF. जैसे ही ये convert करेगा HbA को HbF में, then yes, sickle cell anemia, target cells are also there. You guys are right. So HbF is going to have more attraction, है ना? There is a very famous meme that ऐसे एक लड़की जा रही होती है, I don't know how to the girl, she's going in this direction and she's looking back towards a guy, and the guy is CO, and but she's going with the oxygen. Why? Because the CO, it's not a CO2, it's a CO, carbon oxide, carbon monoxide. It is going to have much more affinity. Over here, if we talk in terms of HbA and HbF, definitely the girl will be looking at the HbF because she is having more affinity towards the fetal hemoglobin, HbF, है ना? And HbA, अच्छे लोगों को पसंद नहीं आते, right? F people are very attractive, so यहाँ पे भी attraction ऑक्सीजन का ज्यादा होता है towards the HbF. So less symptoms will be there because it is better. In this case, it is going to be better because anyhow the hemoglobin in the normal RBC is not properly working because of the valine. Now coming to the spherocytosis and elliptocytosis. The name itself telling us sphero मतलब spherical. From all the sides the radius is going to be equal. That is spherical. It no more circular, it becomes spherical. Problem क्या है? Problem ये है कि as soon as the circular RBCs convert into the spherical RBCs, they lose the flexibility. Okay, so they lose the flexibility, and elliptocytosis maybe it is going to be same. Now remember, as I told you just now, that अच्छे people do not like अच्छे people. So if someone leaves you, say that they were not good, है ना? We are good. So remember, same thing. Why I'm telling you that spectrin matches spherical, but it is not the most common abnormality here. है ना? अगर मैं पूछूं hereditary spherocytosis में most common abnormality कौन से जीन में होती है? So tell me. And elliptocytosis में कौन से वाले जीन से होती है? Just tell me in the comment box. Okay, so options are these only: spectrin, Antigen, band 3, and there is one more cytoskeleton which is known as glycophorin. That will be there. Okay, so tell me the answer. What should be the answer if I ask you hereditary spherocytosis में कौन सा वाला defective होगा? कौन सा वाला cytoskeleton defective होगा? So most commonly I am asking. Okay, so yes, it can be some other also. Spectrin and band 3 में mainly problem होता है, and Antigen, it is written over there. Okay, elliptical में spectrin. So please remember that S never goes with S. Okay, so S never goes with S. Yes, Antigen, all of you are right. It is written. Raj, Purnima, Osama, Shabaz, you guys are right. So Antigen is going to be there. Why? Because S never goes with S. अच्छे लोगों के साथ नहीं जाते हैं, right? Easily engulfed by spleen. Why? Because they change their shape, and the spleen identify them as abnormal RBC. It start to break them down. So that's why we have to remove the spleen, है ना? Toxic RBC है, remove हम spleen का कर रहे हैं. What is the fallacy over here, right? Now, which of the following has no role? चलो answer दो इसका. Spectrin, Antigen, band 3, glycophorin. This is your question. साइटोस्केलेटन, दिस इज हाउ इट लुक्स लाइक, है ना? साइटोस्केलेटन का अगर मैंने ये वाला पार्ट यहाँ पे enlarge किया and I see under the microscope, I need electron microscope for that, and if I see that, what I'm going to see is cytoskeletal protein. So you can see that both of them are binding to the internal proteins which are helping them to keep that flexibility intact. So tell me what should be the answers. Yes, I'm getting the answers. Till now we saw everything, ankyrin, spectrin, the band 3 also, but the glycophorin usually it is not involved in the any of the diseases, right? Let's move on. Splenectomy. कब कब करते हैं splenectomy? In which situations we are going to do the splenectomy? Emergency, it is going to be trauma. If it is bleeding widely, it is going to have red pulp, which is full of capillaries. So we do not want the patient to bleed to the death, and that's why we have to remove the spleen. Autosplenectomy occurs in the SCA. Can you tell me where the autopancreatectomy occurs? Tell me where the autopancreatectomy occurs. हाँ जी, I guess your medicine and surgery is done, है ना? Planned कब कब करते हैं? Spherocytosis and elliptocytosis. Please remember, S never goes with S, so this is going to be ankyrin, and elliptocytosis के साथ होगा. Most common is going to be spectrin. Okay, autoimmune hemolytic anemia, in that also we can do the splenectomy. Treatment of infection with the capsulated microorganism, you must have learned in the microbiology like pneumococcus, H. influenza, Neisseria, and all these things. Can you guess what is it? What is it? Which type of cells are you looking at over here? Often abdominal injuries like Bilal. Yes. कौन क्या दिख रहा है यार यहाँ पे? What you are looking at in this slide? Just tell me. Yes, blunt trauma. Yes, road traffic accident possible. What are all these? टारगेट सेल, हर जगह टारगेट सेल ही दिखते हैं, है ना? कौन सी बॉडीज दिख रही हैं ये बताओ. Which bodies? Spherocytosis, yes, some are there. Bodies कौन सी है बच्चों? What bodies are there? If I give you the asplenia wala, yes, target cells are there, but again asplenia, if it is there, most common answer is going to be Havel-Jolly bodies. Prosenectomy, nuclear remnants can be seen, है ना? ये जो दिख रहा है आपको, ये क्या है? These are the nuclear remnants which is going to be there. Spherocytosis, चलो ठीक है. Spherocytosis are definitely there, but what is the difference in this? If I mark these cells, that is the Havel-Jolly bodies which can be seen after post-splenectomy. We can see Havel-Jolly. Yeah, hinge bodies are also can be similar, but in that I'm not going to give you the history of asplenia. Okay, G6PD deficiency, जैसे आप लोगों ने बताया, hinge body, Osama, Arefa will come up to this now, right? So XLR, it is going to be in the males. I'm thankful that I'm having 2x, right? So G6PD is not possible, though we can be carrier, but yes, XLR, it is going to happen in the males as it happens in the color, है ना? इनको सिर्फ पता चलता है ये white है, ये black है. Anyhow, the males, most of the males, not all the males, they do not know the color, है ना? Baby pink बोलो तो ये बस dark pink ले आते हैं, right? So this is something like that. So G6PD, glutathione. Usually what happens is जो phosphodehydrogenase होता है वो that protects the RBC from oxidative stress. I told you that you must have learned in the physiology that the homeostasis is important. If anything is much less or much more, nothing is beyond the range, nothing is okay or nothing is good for the body. So if oxygen is there but much more oxygen is going to be harmful, right? So हुआ क्या कि one of the student, he used to read so much so that he got a psychotic attack, right? So बहुत ज़्यादा knowledge भी अच्छा नहीं होता, right? So that is the case. Oxygen बहुत ज़्यादा भी अच्छा नहीं होता. So what happens is oxidative damage. Now with this help of glutathione, I told you that those reactive oxygen species, especially the H2O2, that is hydrogen peroxide, will be converted into the water thanks to this glutathione. But if this is deficient, this G6PD is deficient, then this reaction won't take place, and that's why the oxidative damage will increase and the patient will be asymptomatic at birth, and that's why they won't be giving you the condition of the child. rather they will be giving you a adult scenario, or at least 10 year or 11, 13, 14 years, like that the age will be there of the patient. Stress में symptom आ जाते हैं, so don't take stress, है ना. Keep calm and keep studying. Drugs sulfonamide and quinines, they also can cause this phenomena, and fava beans favism तो होता ही है, right? So what things are seen over here? You can see bite cells first of all. ऐसा लग रहा है किसी ने bite ले लिया यहाँ से, right? And what you can see, these in this cases, these are the hinge bodies that you were telling me, है ना. So हिंज बॉडी अगर बोलना है, जॉल हावेल जॉली बॉडी बोलना है, तो यहाँ पे हमें स्फीरोसाइट यूजुअली नहीं दिखते, राइट. सो व्हाट यू कैन सी इज, फर्स्ट थिंग यू कैन सी द neutrophil over here, which is having 4 lobes almost, and what you can see, the bite cell, है ना, bite cell. And over here if you can see carefully, then you can see the hinge bodies also, right? Bite cell, and इसमें आपको hinge bodies आराम से दिख जाएंगे. In your book, I guess some glucose biscuit and some cream was given, ketchup was given, like that. Okay, you can remember that ways. I didn't find out very good mnemonic, so I'm just going out with that. The hinge bodies are going to the way, and bite cells, right? Why? Because the spleen eats up. Okay, spleen eats up that hinge bodies out from the RBCs, and that is what is going to happen in the G6PD. Okay, let's move on to MAHA, MAHA, that is the microangiopathic hemolytic anemia. इसमें hemolytic है तो हमें helmet cells दिखेंगे, broken RBCs, again schistocytes will be seen, and this can happen due to many reasons. कहीं पे भी कोई obstruction है, the RBCs are going to have the scenarios with them, and definitely they are going to break away, right? So they are going to obstruct and they are going to break away. This can be many reasons. Any implants are there, any calcified valves are there, so they are going to be stronger. Thrombus is there, DIC is there, and hemolytic uremic syndrome is there, or TTP is going to be there. You can see this is looking like a helmet, so this is the helmet cell, and schistocytes, most of them are of the schistocytes. So hereditary this thing, schistocytes or the helmet cells are going to be seen in the MAHA. Perfect balance, right? So autoimmune hemolytic anemia, it is associated with CLL. How you are going to identify CLL? Can you tell me something about CLL? Whatever you remember from yesterday's class, tell me about CLL. It is lymphoblastic or lymphocytic leukemia. चलो, spherocyte can be seen, and यहाँ पे हमें पढ़ना है 2 antibodies M and G. We used to remember like G for garam, है ना? So it is going to be warm type, and children are usually want to be warm, right? They get the warmth of everyone, that is the children, young and females, yes, females also, and colds. Cold क्या होता है? M. The remaining one is cold. So AIHA, it is related to associated with M for mycoplasma, EBV, and elderly. They do not, they are cold, right? Cold hearted. Lymphocytic, right? चलो जी आगे देखते हैं. What are these cells? Are they circular? Are they looking like circular? कैसे पहचानेंगे? This is a circular shape. Why? Because I can see in between a paler which is not very prominent as target cell, but it is there, है ना? So हल्का सा एक paler आएगा बीच में, that is mainly circular, right? If you cannot see that, you can see that this is what? This is what? नहीं आप पढ़ाई करो शाबाश. So this is a spherocyte which is they are showing us. Okay. So see, there is a difference between the normal erythrocyte and spherocyte. It becomes spherical. This is a normal circular disc shape, right? And glycophorin, all these, and chitin vagara, I told you, if there is any thrombus or endothelial injury, this is going to break away. So these are going to break away very, very easily. कौन सा डायग्नोस्टिक के लिए टेस्ट करते हैं? अगर मुझे एंटीबॉडीज चेक करनी है, व्हाट डायग्नोस्टिक टेस्ट आई कैन रन? डायग्नोस्टिक टेस्ट कौन सा रन करेंगे हम? यस गाइस, Okay, this is again hampered. Something happened over here. Okay, so antibodies अगर मुझे देखने हैं तो I'm going to run the yes, Coombs test. Everybody has given me the answer. They have given me. ELISA नहीं करेंगे सोनू. Coombs test. We are going to follow the Coombs test, right? And treatment, obviously, we cannot help it out. So we have to give the steroid so as to decrease or suppress our immune system. IVIG दे सकते हैं और distract करने के लिए spleen को, right? And splenectomy करेंगे. If possible, then Havel Jolly bodies are going to be again there. Now, what is PNH? PNH is paroxysmal nocturnal hemoglobinuria. Now, why this is going to occur? First of all, we'll go on to the next slide. See over here. Usually, Pigagen normally X chromosome में होता है, right? And they do have the DAF and Mirror. Now, decay accelerating factor and Mirror, that is CD55 and CD59, if they are there, in the night, usually what happens? Respiratory depression occurs. Okay. So, as compared to the awake system, in the sleep, what happens is our respiratory system, because we do not need much of the oxygen because we are not working, we are not awake. So, we do not require that much of the oxygen, we do not require that much of the ATPs, and that's why aerobic system is not that working. So that's why respiratory centers, they are slightly suppressed as compared to the daytime. So what is going to happen at the night time? Because most of the people sleeps at night, right? So at that time parasympathetic will be active, and at that time our respiratory rate is low. So deoxyhemoglobin will be much higher. Now as soon as the oxygen levels are less, your complement system, as soon as oxygen levels are less, the complement system is activated. As the complement system are activated, they want to attack on the RBCs. Okay, so they want to attack via forming MAC complex. I hope you know that is C5 to 9. They form a MAC complex, that is membrane attack complex. But thanks to these DAF and Mirror, what they do is they prevent this complement activation. They do not allow the complements to attach and form a pore on the RBC membrane. So that's why this is prevented. But what if? So they, DAF and Mirror, they act as guards over here. So if they are not there, what is going to happen? They are going to form the MAC complex, and definitely the hemolysis will occur, and that's why this happens at the night. Why? Because again I told you that the respiratory depression occurs as compared to the respiratory centers are suppressed in the night time. Why? Because the person is sleeping usually, and that's why this happens in the night time. So that is going to be the PNH, that is paroxysmal nocturnal hemoglobinuria. Okay, so defect is in the Pigagen, as you guys told us, right? Okay, so DAF and Mirror, it protects the RBC from the MAC complex. This is not the MAC book that it is talking about. It is talking about the membrane attack complex. Membrane attack complex, right? Diagnosis, HAM test and sucrose lysis test, flow cytometry. Obviously, at least if you want to remember one thing, please remember the HAMS test, and eculizumab we can give, this blood transfusion, and stem cell transplant can be given. Why? Because again the Piga genes are not there, so it's better to give the stem cell transplant. It is going to be the permanent solution and not the pancytopenia, hepatosplenomegaly. Again we discussed this. If you take the sample of the patient in the morning itself and you consecutively take the samples, these will look like this. This came in your exam itself 2 years back. So please remember this. If such urine samples are shown, this is not a blood sample. Remember, it's looking red. Why? Because the hemoglobin pigment actually gives the because of the hemolysis, it gives the hemoglobinuria. So it gives the red color to the urine. Even that is the reason why our even RBCs are red, because this is the pigment which gives the red color. So consecutive urine sample, in that we are going to see this red urine becomes actually the yellowish as the day progresses. Why? Because the oxygen, the respiratory centers start working and the oxygen will be more, and that's how it is going to, the hemoglobin stop coming into the urine. Now, coming to the vitamin B12, it is a very nazuk kali. What is nazuk kali? That means it is a very, very delicate type of vitamin. It requires, yes, it helps us out in many things, but it requires a lot of protection. Like a girl, first of all, the dad will take care of the girl. Nobody should come near this and that. Then the boyfriend will take care of the girl, right? So girl requires a lot of protection, especially in Delhi-like condition. So what happens is, first of all, as soon as the vitamin B12 goes into the mouth, we do have salivary glands over there. We know that they are going to go, this vitamin B12 is going to go in the stomach, and stomach mein bahut sare, chichore bande hote hain, right? So what is that? The HCl. The HCl is going to break away the vitamin B12, and that's why we want to protect it. So who is going to protect it? Heptocorin is going to release by the salivary gland, and it is going to bind to the vitamin B12. It forms a core like thing, and it won't allow the vitamin B12 to break down. Now, important part, who is going to protect the vitamin B12 in the stomach? Please remember, the heptocorin is going to protect the vitamin B12 in the stomach, unless and until the intrinsic factor is bound to the vitamin B12, it will not protect it. It is released from the stomach. The intrinsic factor is released from the stomach, but it binds to vitamin B12 in the intestine, especially D2 part mein it is going to bind. Why? I'll tell you that. But please remember, intrinsic factor, though it is released in the stomach, it won't be able to bind to the vitamin B12. Abhi impress karna baki hai, right? So abhi thoda sa patience chahiye. Then the heptocorin and vitamin B12 comes in the stomach. The heptocorin is still there, so vitamin B12 is going to be protected. In that, the intrinsic factor will be released from the parietal cell. Now what happens is, at a time only one thing, the girl can remain with the one guy only, either heptocorin or intrinsic factor, right? So it is already bound to heptocorin, right? So it cannot come in the relationship with the intrinsic factor. So intrinsic factor waits for it, right? He applies some villain, so what happens in the pancreas, in the D2 part, the sphincter of Oddi opens up, and in the pancreatic juice we do have pancreatic proteases. Now these proteases act as a villain to the heptocorin. They break away the heptocorin away from the vitamin B12. Now vitamin B12 is again single now, ready to mingle with the, yes please, the intrinsic factor. At a time only one thing can bind, so heptocorin leaves from there, because the proteases, they are going to break away the heptocorin from the vitamin B12. As soon as the intrinsic factor gets the chance, it covers the vitamin B12 and protect it from the destruction. We want to digest it and absorb it, not destroy it. So vitamin B12, very delicate kind of a vitamin. We have to prevent it from the destruction, and we do not allow it to destroy. Not true, ma'am. Okay, whatever is true for your thing, you just believe it. Okay, now intrinsic factor is going to protect until what time? Unless and until it gets absorbed in the terminal ileum. So please remember, the vitamin B12 is going to get reabsorbed in the terminal ileum. Okay, now pernicious anemia. What is pernicious anemia? If the antibodies are formed against the parietal cell, they are going to kill the parietal cell. If the parietal cell is not there, and so if the parietal cell is not there, what is going to happen? The intrinsic factor won't be released. There is no one to protect the vitamin B12 in the jejunum and the other part of duodenum. As soon as the pancreatic juices are going to be there, they are containing a lot of enzymes. Then the intestine has its own enzyme. The HCl is coming from the stomach. Definitely the B12 will be destroyed and not digested. So it will be destroyed, and that's why in the pernicious anemia, there is a deficiency of vitamin B12. Okay, now tell me what you're going to, if you identify that this is the pernicious anemia, can you just give vitamin B12, or you have to give something else also? What else you can give? Tell me. There is no absorption, right? So that in that case, in the pernicious anemia, what you want to give to the patient, just tell me that. Alcohol से pancreas खराब हो जाता है, pancreatitis हो जाता है, right? So that is going to cause again the vitamin B12 deficiency, which will lead to megaloblastic anemia. Okay. So the answers are coming very late, so I'm just telling you that in the treatment, not only vitamin B12, but with that you have to provide the intrinsic factor also, then only. Why? Because the intrinsic factor is very, very important to protect the vitamin B12 in the jejunum and other parts of the proximal ileum and duodenum, terminal duodenum also. Megaloblastic anemia, as you guys told me, vitamin B12 deficiency or the antibodies against the parietal, that is pernicious anemia, dietary deficiency if the person is veg, and pancreatitis. Tubulin receptors are there if there is a mutation. Emerson-Grespec syndrome can be there. Nobody is going to ask you the question, but it was there in the notes, so I added it. Infection, surgery. This is a typical case that they are going to give you, that road traffic accident happened and then they did the surgery in which they cut the jejunum as well as duodenum and this terminal ileum. So what the patient will come to you with the symptom of? Definitely terminal ileum is gone. So please focus on that terminal ileum wala part. They are telling you, or they are hinting you towards the vitamin B12 deficiency if you remove the ileum with the surgery. This is a typical case that they give. बड़ा सा 3-4 lines का case होगा in which the patient had the accident and then he came for the surgery. We have to remove the part of the intestine, that is nothing but the jejunum or ileum, and what is going to happen? B12 deficiency, because it won't get absorbed. यहाँ पे folic acid में क्या क्या होता है? Demand increase हो गया, which is normal in the children, growing children. Demand is high, right? Pregnancy में demand is high. Or we just now read about the methotrexate also. In elderly, the reabsorption is decreased in the folate of the folate. So that's why over there the deficiency occurs. And the methotrexate, important, phenytoin. Nowadays they are giving less of the phenytoin and giving more of the modern drugs. My own mom, she was on phenytoin, but now it is changed to levetiracetam. Yes, it is changed to levetiracetam, right? So vitamin B12 and folic acid deficiency, megaloblastic anemia, everybody know, big size, that means more than 100, hypersegmented neutrophil, yesterday we learned that, and homocystinemia will be there. Vitamin B12, terminal ileum ko cut kiya, neurological symptoms will be there. Methyl malonic acid will be there. Schilling test करते हैं. Schilling test में क्या करते हैं? First of all, we check vitamin B12 से कोई effect आ रहा है या नहीं. Then if it is not there, vitamin B12 plus intrinsic factor. If it is not there, that means absorption में problem है. So we can give it IV also, right? So all these things step by step we do. That is Schilling test. So important है Schilling test and SACD. What is SACD? Tell me, what is SACD? Which is related to this neurological symptom. Folic acid absorption जो होता है वो jejunum में होता है. There is no neurological symptom. The methyl malonic acid SAM, which is going to be normal. Figlu test, which is going to be there for this, and this SACD is going to be absent. And that is how you are going to identify whether it is folic acid or vitamin B12. Why? Because hypersegmented दोनों में दिखता है. Megaloblastic anemia दोनों ही है, folic acid as well as vitamin B12, just with the help of neurological symptoms. If they mention this neurological symptom, it cannot be folic acid deficiency, subacute combined degeneration of spinal cord. Again, this is a neurological symptom that is going to be only present in the B12, है ना? बड़े वाले में B12 में SACD and neurological symptoms can be there. Aplastic, plastic modulable, right, or proliferating cells are not there. Usually it is going to, there are two types of cells which can divide and which cannot. Most of it is going to convert into adipocyte. Most of the time this is the reason why this is happening, है ना? So MSC cells, it's this hematopoietic stem cell, either they are going to form multipotent stem cell. They can form either multipotent stem cell or they can convert into adipocyte. अगर बहुत ज़्यादा adipocytes में differentiation हो गया, definitely what is going to happen? See over here, that's why I'm very glad that I'm a female, right? So estrogen again, that is going to cause the proliferation also. Bone marrow aspiration में 1000 बार पढ़ चुके हैं हम, the dry tap is going to be there, fat cells will be there in the biopsy also. This can be because of Fanconi's anemia, Schwann-Diamond syndrome, the Schwachman-Diamond syndrome, and the drugs, that is NSAID. They are not going to ask about these syndromes, please, just they were there. So please remember NSAIDs. They are going to give the more common scenarios, that is like NSAIDs, okay, or anti-cancer drugs. Both can cause the aplastic anemia. Let's move on. If fails तो बोन मैरो ट्रांसप्लांट तो हम हर किसी में करते हैं. ट्रीटमेंट में पैनसाइटोपिनिया का ट्रीटमेंट करना पड़ेगा आपको, जो भी सेल्स कम है हमें देने पड़ेंगे. ब्लड ट्रांसफ्यूजन, स्टेम सेल ट्रांसप्लांट थेरेपी, एरिथ्रोपोइटिन को इंक्रीज करना पड़ेगा एज वी गिव द थेरेपी इन द CKD, दैट इज द डार्बोपोइटिन एंड इपोइटिन. we can give that. Recombinant EPO can be given. Okay, platelets and WBC increase करने के लिए भी we can use some drugs. Okay, if all those fails, bone marrow transplant. Now what is this? This is a line of Zahn, है ना. Line of Zahn में हमें क्या दिखेगा? फाइब्रिन और RBCs के लेयर्स दिखेंगे, राइट. सो इट इज नॉट रिटन ओवर हियर. नेक्स्ट स्लाइड में रिटन है बट दैट स्लाइड इज नॉट गुड. सो व्हाट इज दिस? दिस इज अ फाइब्रोसिस वाला लेयर. सो यूजुअली द प्लेटलेट्स एंड फाइब्रोब्लास्ट दे एक्यूमुलेट. सो वाइट कलर की लाइन आती है ऐसे, राइट. and these are the RBCs which can be seen in between. So it is kind of a thrombus which are formed. So this is known as line of Zahn. Okay, the last thing in the RBCs, then we'll start off with the platelets, the smallest plate-like cells, right? So up यहाँ क्या देख रहा है? Nostroph negative is a good thing and positive is not a good thing. Why? Because you can see this is a normal distilled water में and this is buffer state में. So what you can see is you cannot see the lines behind whichever are there, right? So that means what happens over here? That means hemolysis is there. So the osmotic fragility is increased there. Can you tell me what are the conditions in which the osmotic fragility will be increased? And there is only one condition. And what is the condition? How you can remember in which condition it is going to decrease? Yes, please tell me in which the fragility will be increased and in which the fragility will be decreased, guys. Nostroph test, naked eye single tube RBC osmotic fragility test, which is going to be positive. That means you have a condition. किस में होगा? ऑलरेडी कोई गोलू मोलू सा आदमी, ऑलरेडी भरे हुए पेट में आप भरे जा रहे हो, ठूसे जा रहे हो, ठूसे जा रहे हो. पूर्णिमा, थैलेसीमिया में क्या होता है बच्चे? इंक्रीज और डिक्रीज. राइट पूर्णिमा, यू आर ऑल्सो राइट. सो प्लीज रिमेंबर, डिक्रीज में सिट निमोनिक. आई कम ऑन टू दैट. दैट इज नॉट ओनली थैलेसीमिया, IDA में एंड सिट्रोब्लास्टिक में भी दिस इज गोइंग टू टेक प्लेस. एनीवेज, सो इंक्रीज किस में होती है बच्चों? इंक्रीज एक ही में होती है. गोलू मोलू चीज में और चीज आप भरे जाओगे, है ना. सो व्हाट इज गोइंग टू हैपन? एज सून एज spherocytosis, elliptocytosis, what they do? They already spherical shape, they are having the maximum surface area covered already. There is no flexibility, there is no concavity to balloon out. So that's why as soon as even the slightest amount of water or the saline goes inside the RBC, they start to burst, है ना. So their flexibility is very less, so their fragility is much higher, है ना. So this is the fragile RBC which is going to break away in the spherocytosis and it is going to decrease in the thalassemia. So please remember that not only that, in the sickle cell anemia, IDA, that is iron deficiency anemia, and thalassemia, in these three conditions, the osmotic fragility testing या Nostroph testing में fragility is going to decrease. That means you can see there is a time limit, right, for this Nostroph test also, depending on how much solution of what concentration that we made, that if the osmotic fragility, the cells are not breaking away easily, that means they are more flexible. SCA में I told you that they becomes like this. So they have more space to carry the saline. So that's why their fragility is going to be much later. And in case of the spherocytosis, either that can be acquired or genetic. Already the size is big, है ना? कितना एक मोटू चीज में कितना और घुसोगे, right? So it is going to break away. It won't be containing much of the space for the saline or water. It is going to be right away breaking part. How will jolly bodies? So obviously we saw the nuclear remnants, that is DNA will be there, asplenism, hyposplenism, hemolytic anemia way, which is going to be there. And please remember, hinge body, there is something known as supravital stain. Now what is supravital stain and what is the vital stains and non-vital stains? There are only two types of stain per se, supravital, intravital. They comes under vital staining. Vital means what? We are going to arrest the cell in that metabolic and that physical state itself. So what we do is, we do that in the lab, that we take the blood out and we keep that, we add the stain and we keep them into the 37 degrees Celsius, which is the body temperature. So we required the water is there, it's like the steams are going on, and we maintain the, in that incubator, we maintain the 37 degrees Celsius ka temperature. So in that case, what happens is, it is still having the environment or that temperature, so it is acting as a living kind of an environment, okay? So that's why the stain only can enter in the 37 degrees Celsius. So we have to maintain the vital conditioning unless and until the stain enters into it. And the stain contains a lot of things which are, especially the methylene blue and all, what they do is they maintain the metabolic state. They arrest the metabolic state, so there is no metabolism. So glucose cannot be used and the cell will be in the vital condition, and that is known as supravital staining, especially the RBCs and reticulocyte. जब भी हम reticulocyte का कर रहे होते हैं तब we do this supravital staining, important, right? So inclusion इसमें hemoglobin का दिख सकता है, especially एक ही चीज याद रखना, G6PD. Only one thing remember, do not remember these things, okay? Pappenheimer bodies, we discussed that iron deposits हो सकते हैं, thalassemia, sideroblastic anemia, splenectomy possible. Then hemoglobin H inclusion, not really require hemoglobin H disease, not really required. Basophilic stippling, please remember all of them, important, okay? We do not require to remember this. So please remember these things. Yes, basically we are stopping the metabolism, we are arresting the metabolism. As soon as the stain part or that effect of that stain is over, the metabolism will restart again. They won't die, they will stay alive in the slide itself, right? Change brings challenges. Challenge learning and sense of new. So let's start something new. We got bored with the RBC. Change is full of promises. So hopefully the platelet is going to be much more interesting as compared to the RBCs, right? So let's start with the hemodynamics. Hemo means blood, dynamics means something dynamic is occurring, right? Let's do some actions. Okay, so platelets, they are responsible for hemostasis. What is hemostasis? Stasis has two parts in the physiology per se. Stasis means either to stop or to maintain. Whenever the injury occurs, we want to stop the bleeding, and whenever it is inside the vessel, we want to maintain their fluidity, right? So whenever you are in the class, we want to make you concentrate on the topic, and whenever you go out, we can do a fun too. So maintain the blood in the fluid state and clot formation whenever it is going to be required. Remember, it is not just clot formation, otherwise intravascular में clot formation हो गया, so definitely it is going to be, so yes, I hope Roy that happens. I'll be more than happy to, you know, listen from you guys that ma'am, whatever you taught, this came in our exam, right? And we did it correctly. So very important, okay? So clot formation, if that happens unnecessarily, that is going to be problematic too. So whenever it is required, then only the clot should be formed, है ना? Unnecessarily form हो गया, जैसे किस कंडीशन में होता है बच्चों? yesterday also we talked, that is disseminated intravascular coagulation, which is not a good condition. Okay, now there are two terminologies which are going to come, adhesion and aggregation. Who comes first? D comes first or G comes first बच्चों? D comes first or G comes first? Only D comes first. A B C D है ना, LKG में नहीं जाना हमें वापस. A, B, C, D, D comes first. So please remember, adhesion comes first. So what is the difference between adhesion and aggregation? If the platelet is attaching to the disturbed, or जैसे ही the injury occurs and the blood is exposed to the collagen which is there under the vessel wall. As soon as it is exposed to the collagen, what is going to happen? Definitely, the platelets are going to get activated. That something is happening, right? Let's do some action like that. So yes, Haripriya, RFI, you guys are right. So that is going to happen. So as soon as, suppose this is the blood vessel, as soon as the vessel is going to break away, definitely there is externa, which tunica externa, in that we are containing collagen. So as soon as the blood comes in the contact of collagen, what is going to happen? Then they will be activating something known as von Willebrand factor, which is going to activate the platelets. So they are going to come in the relationship now and they are starting the action, right? So they are attracting more and more platelets. Remember, the first line of platelet which are attaching to the vessel wall, that is known as adhesion. The next layer of platelet which will combine and bind to the next platelet which is already there. So this is the vessel wall. If on the vessel wall the first layer of platelet is formed, vessel wall and platelet relationship, that is a true relationship, that is called as adhesion or stickiness. If the platelet, next platelet comes, they bind to the platelet which is already there on the vessel wall, that is known as aggregation. Double G आ रहा है, so aggregation means platelet bind to the platelet. Adhesion means platelet binds to the vessel wall. So पहले adhesion होगा, then comes the aggregation, and ultimately fibrin will be formed and the clot will be formed. Now what we have to remember, 1, 2, 3 है ना? So we have to remember 1, 2 and 3. What is this 1? Just add BBA. Right? So what is this 1, 2 and 3? These are the receptors which are having or allowing to have that relationship, है ना? इंडिया में जैसे अरेंज मैरिज होता है ना, so जो पंडित जी होते हैं, so they are acting as a पंडित जी, है ना? So who is acting the receptor between the, or receptor for the adhesion per se, that is going to be obviously D come first, so adhesion में 1B is going to be there and aggregation में both are going to be there. And which type of 1B? There is GP, that is glycoprotein. GP means it is a short form for glycoprotein 1B. And if you want to remember the full thing, that is GP1B9 is going to be there, which is going to help to form that receptor or that action, right? So adhesion के लिए, संगम करने के लिए कौन पहले जरूरी है? So that is going to be 1B, right? Then comes the another thing, है ना? पहले क्या होता है? पेरेंट्स से बात होती है, फिर actual बंदों से मिलाया जाता है ना? So A and B, who are actually the ones which are going to come in the relationship. So in that we need that receptor, that is 2B and 3A, which are going to form a complex, and then the platelets, more and more platelets will be aggregating, है ना? Platelets जब एक दूसरे के साथ जुड़ते हैं, that is known as aggregation, and platelets and cell wall, that is known as adhesion. Now there are factors which enhance the thrombosis, there are factors which reduce the thrombosis. So antithrombotic, NO is universal vasodilator. So vasodilator हो रहा है तो एक दूसरे से चिपकना मुश्किल है, right? More the expectation, less will be the relationship status, right? So NO and PGI2, that is going to be antithrombotic. Heparin, again we give heparin and warfarin, especially after the transplant and all. Why? Because we do not want coagulation. So you can guess that heparin-like molecules, they are not there. They cannot cause the thrombosis. Thrombomodulin, it modulates the thrombosis, and that's why it inhibits. So it is antithrombotic, especially the acting via this protein C and protein S. Protein C, protein S, what they do is they inhibit, you must have heard of factor number 5 and factor number 8. They are helpful in the clotting process. We'll see the clotting process. So protein C, protein S, what they do, they go and inhibit this 5-in-8. Okay, so if the 5-in-8 is not there, definitely the clotting won't take place, and that's why they act as a anti-thrombotic factor. Plasminogen, what the plasminogen is going to do? It is going to break away the plasmins, okay, and those are the threads which are important. Thread formations are there, and streptokinase, plasminogen, what they are going to do is they are going to break away whatever fibrin threads are there, and that's why the clotting, the permanent clot cannot be formed. So they act as an antithrombotic again. Opposite, thromboxane A2 and tissue thromboplastin and plasminogen activating inhibitor. So if it is inhibitor, they will be giving you PAI. This is a standard short form. Hemoglobin के लिए जैसे HB लिखते हैं, that is a standard short form, universal short form. Same over here. PAI is going to be universal short form for this plasminogen activating inhibitor. Right, thrombotic, antithrombotic factor. Let's learn about intrinsic, extrinsic pathway. This is looking very intimidating. Just remember the extrinsic is shorter, x is shorter, है ना. x को ज्यादा भाव नहीं देना होता है, but जो आने वाली है उसको भाव देना होता है. So intrinsic is longer, right? So you give much more time to the intrinsic and not to the extrinsic. जो जा चुके छोड़ दो पीछे, है ना. So कम टाइम, उन पे कम थॉट लगाओ, जो आने वाला है उस पे ज्यादा थॉट लगाओ. Intrinsic, right? So much more longer. Intrinsic is going to be longer. That's how we used to write. So x is smaller, so that's why smaller, and there is something known as PT and APTT. The longer the chain, the longer the investigation name also. So APTT, partial thromboplastin time, that is going to be definitely for the intrinsic, and the prothrombin time, it is for the extrinsic. Now we can make it smaller also. Clotting cascade, just I'm giving the overview how to revise that. Intrinsic, I'm going to write over here extrinsic. Okay, intrinsic में what is going to happen? Factor number 12, 12 से पहले कौन आता है? 11, 11 से पहले कौन आता है? 10. But let's make it interesting. We'll first take 9 and then we are going to take 10. Okay, and in between this we are going to take 8, factor number 8. Okay, now extrinsic में 7, to activate 7 we require 3 plus 7, that will become 10, right? And 10 with the help of factor number 5, right? 5 into 2 is 10. So 5 into 2 is 10, and that will activate factor number 1, that is going to be first factor, fibrinogen. Then factor number 13 will be activated, that is the fibrin stabilizing factor. So please remember this. This is the common pathway, this is the extrinsic pathway, and this is the only intrinsic pathway. The one thing I told you, that factor number 5 and factor number 8 are important. Who are going to inhibit them? Protein C and protein S, right? So if they inhibit them, they are going to act as an antithrombotic, and that's how they are going to act as an antithrombotic. I told you in the last slide itself, right? So same thing is given over here. This A is written, that means it is going to activate. Now who is going to activate them? The damaged surface, that means collagen exposure. Basically the collagen exposure, or even if you take that in the glass tube, the silica will be there, which is going to activate them. Extrinsic में trauma is going to activate them. Okay, so just remember them. So that is going to happen over here. So same thing, 12 से 11 से 9 से 10, है ना? And then comes the 5, 2 and 1. 5 2s are 10. So that is going to be there. This is the common pathway, same for the both the things. Okay, so please remember that. 7, actually for factor number 3 will be activated via the trauma, and then the factor number 7 will be activated. 3 plus 7 is equal to 10. So please remember this chart. Okay, so I have something in this slide, so I am removing this. Please remember, ulti ginti karni hai, just you have to change a bit over there. Okay, you won't be forgetting at all. And longer the pathway, longer will be the testing also. So APTT and PT. Right. One more thing that I want to tell you, that last slide we discussed about PT and APTT. So please remember over here that the timings also How much is the timing? Over here it's a shorter pathway, so we are going to give around 15 to 20 seconds, which is normal PT. APTT, over there was only 2 alphabets. Over here it is 4 alphabet. To make it double, 15 ka double, 30 to 40 seconds is going to be the APTT. Okay, so easy to remember. PT, 2 alphabets, 15 to 20. You can remember 20, 2 alphabet, 20, 4 alphabet, 40. Okay, and shorter the pathway, shorter will be the testing alphabets, and longer will be the pathway, longer will be the alphabets, that is APTT. What can be the symptoms of disorders? If there are disorders, whether that be in the adhesion or aggregation, it is going to be platelet defects, then clotting disorder, BT, CT, all these things will be checked. Okay, CT में defect है तो क्या check करोगे? PT and APTT you are going to check. स्पेशली अगर प्लेटलेट में डिफेक्ट होगा तो बीटी बढ़ जाएगा. ओके, एंड प्लेटलेट में डिफेक्ट नहीं है तो बीटी नॉर्मल रहेगा. दैट मीन्स द प्रॉब्लम इज इन द क्लॉटिंग फैक्टर्स. ओनली उस सिस्टम में प्रॉब्लम है तो दैट इज गोइंग टू बी क्लॉटिंग फैक्टर डिफेक्ट. दैट इज इन दैट वी आर गोइंग टू चेक क्लॉटिंग टाइप. सो हीमोफीलिया as we discuss, A, B, C, 3 type के होता है. I don't know whether I mentioned that in the slide, or 8, 9 and 11. Please remember 8, 9 and 11. How I told you to remember? A sounds like 8, B ulta karo, it will be 9, and C is going to be 11. Liver disorders mein it is going to happen that the tissue plasminogen activator will be there, and that's why plasminogen activator is going to be there, and that's why the CT is going to increase. Why? Because it is, I told you, plasminogens, streptokinase, urokinase, ये सब क्या करते हैं? They are going to break away the fibrin threads which are going to be form over there, right? So liver disease में क्या होता है? एक तो हमारे clotting factors नहीं है, plus इसमें जो receptors होते हैं GP1, B9 and all, they won't be working because again they requires the protein. So both BT and CT increases, both will be increase. Right. So tissue plasminogen activator, I told you the role of that already. This is the petechia and purpura. It is different than the other things, है ना? When this is going to happen? When the petechia and purpura is going to take place, when there is a bleeding disorder. This is a bleeding disorder. Okay, so platelet में defect है इसमें. Okay, if I show you the clotting disorder, right, this is going to be something else. So easy bruisability. Yesterday I was telling you about the easy bruisability. This is the easy bruisability. It is not actually the, there will be no history of trauma, but yes, wherever the pressure points are going to be there, that is going to be okay, that is going to be the INR is same as APTT. Okay, thrombin. अब thrombin क्या करता है? ये thrombogen, the fibrinogen thrombin is formed. It is going to break it down into fibrin monomers and the fibrin polymers. Then the fibrin polymers will be formed. Thrombin is what? Prothrombin से thrombin बनता है, right? So that is going to be factor number 2. Actually, this helps us to form the fibrin, and with the calcium it is going to form the fibrin clot. Not important really. So look over here, that I was talking about the tissue plasminogen activator. What it is going to do? It is going to be causing the activation of plasminogen. Just forget this cross till now. I'm telling you the reaction. So if the plasminogen is active, what is going to happen? This will activate the plasmin, and this plasmin will break away this fibrin clot into the degradation product, which we call it as FDP. है ना? जब COVID हुआ था, in the COVID times, the FDP was very, very high because there was unnecessary activation of the platelets. So that means adhesion aggregation was occurring. That means clotting was occurring. That means fibrin was formed, fibrin thread was formed, fibrin clot was formed. But the body activated the plasminogen because we wanted to make sure that the flow is constant to the organs. So definitely in that case, the plasminogen, the plasmin was active, and FDP products was increased. In the inflammatory condition also, it is going to increase because of the cytokines, right? And if you give the antiplasmin over here, what is going to happen? The plasmin won't be able to act. The fibrin clots will remain like this. It won't break away. If you give the fibrin plasminogen activator, the plasminogen activator is going to be activate much more. If you get inhibitor again, then inhibitor, what the inhibitor is going to do? Inhibitor is going to make sure that the plasminogen won't get activated, and this reaction FDP will not be formed. So what is FDP? It is fibrin degradation product, which is going to form with the help of all those streptokinase, plasmin, urokinase, all these things. Okay. Now let's talk about some test which is known as RAT. What is RAT? Ristocetin assay testing. देख के बताओ क्या पता चल रहा है? What you are looking at over here? What can be seen over here? क्या दिख रहा है बच्चों? What can be seen in this case? Now see over here, actually this ristocetin cofactor, it helps to bind the platelets to the von Willebrand factor. So there is a factor 8 and von Willebrand antigen levels. We do that usually. Basically what it does, I told you, पहले पंडित जी का काम आता है, right? So von Willebrand factor and platelet, it helps the platelet to bind to that wall, right? So it acts as a adhesion maker, right? So पंडित जी का काम जहाँ पे भी आता है वहाँ पे rat आएगा, है ना? They're like a चूहा. So adhesion helps by the rat. Okay. So platelet adhesion में this is going to help us out, and this is going to, obviously GP1B9 was there. Adhesion I told you decome first, so 1B9 को help करता है to bind with the adhesion. Now this is very important chart. If you even remember this, most of the question will be solved very easily. Now platelet में दो type of defect is there. First is count defect if the counts are less, and second is functional defect. First of all, let's talk about the count defect. The case will be telling you that there is a thrombocytopenia. That means the thrombocytes are less. Okay, less than 1 lakh is taken as thrombocytopenia. What is the normal level of platelet? Please let me know in the comments. What is the normal level of the platelets? Okay, then there are two things can happen in the thrombocytopenia. First, it can be immunogenic or non-immunogenic. Immunogenic में obviously immunothrombocytopenic purpura. If it is non-immunogenic, it can be thrombocytic thrombocytopenic purpura or HUS, right? Hemolytic uremic syndrome. Each of them we are going to talk in detail, but for now just remember that this is going to occur if there is a count. But the case, if you are making such kind of diagnosis, you should see whether the case is mentioning or whether the question is mentioning thrombocytopenia or not. If the functional defect is given, then it cannot be ITP, TTP or HUS. Functional defect is there, then it is going to be either adhesion defect or aggregation defect. Yes, you guys are right. Shabas, you are correct. Roy and Osama. It is 1.5 to 4 lakhs. 1.5 to 4 lakhs. Somewhere between in the WBCs and RBC. WBCs are already in the thousands. The platelets are in lakhs. RBCs are in millions. Okay. D comes first and over here B comes first. So please remember adhesion defect है. Adhesion. D को उल्टा करो B बन जाएगा Bernard Soliers. कहीं पे भी GP1, B9 or ristocetin assay test is negative. Such kind of hints are leading you towards Bernard Soliers, and aggregation में double G आ रहा है. So please remember it is, if the aggregation is defective, then it is going to be Landsteiners thrombocythemia. Okay, so it's very easy. If you know this chart, most of the question you are going to solve very quickly. Okay, so first of all, let's discuss about Bernard Solier and Glanzman. We know first defect is, इसमें किसमें defect है? The adhesion defect is there, and यहाँ पे aggregation defect is there. Obviously, the receptor is going to be different then, right? So what is going to happen? Both of them are AR condition, that is autosomal recessive disease. Now remember the defect in the receptor. यहाँ पे मैं the Bernard Solius I'm going to write. I hope I didn't mention it. Okay, so Bernard Solius I'm going to write over here, and Glanzmann thrombocythemia I'm writing over here. Bernard Solius में obviously 1B GP1B9 में डिफेक्ट होगा, यहाँ पे 2B और 3A में डिफेक्ट होगा. So that is going to be problem in the aggregation, है ना. Platelet counts क्या रहेंगे बच्चों? What is going to be the platelets count? Is it a defect in the platelet function or count? So you guys will tell me what should be the platelet counts. Okay, tell me what will happen in the platelet count. BT, what is going to happen to the bleeding time and bleeding time? Remember, the CT, APTT and PT, there is no problem in the clotting. We haven't even reached the clotting. अभी हम adhesion aggregation की बात कर रहे हैं. After the aggregation, the clotting will start. There is no problem in the clotting. Clotting factors are absolutely normal. So this is going to be normal. The platelet counts, this is a functional defect and not the count defect. So it is going to be normal. Yes, Roy, you're correct. It is going to be normal. BT में क्या होगा बच्चों? What is going to happen to the bleeding time? If the platelets are not able to aggregate over there, obviously the BT is going to increase, right? Yes, Roy, you are right. So GP1B9, yes, GP1B9, it is going to be the receptor. Bilal, it is the receptor in the Bernard Solius. Okay, platelet count will be normal, but this is a functional defect. BT क्या होगा बच्चों? BT दोनों cases में बढ़ जाएगा. Okay, in both the cases BT is going to increase. Fine. And RAT will be negative. Why? RAT is positive means everything is fine, है ना. पंडित जी है तो सब कुछ हो जाएगा अल्टीमेटली, बट पंडित जी नहीं है, रैट नहीं है, चूहा नहीं है, स्टिकीनेस नहीं है, तो ब्लीडिंग वोंट स्टॉप, है ना. वी रिक्वायर दैट स्टिकीनेस इन द, दो परिवारों का संगम होना जरूरी है टू मेक द marriage happen, right? So if the panditji is not there, there will be no stickiness, right? So rat will be negative. So rat will be negative over here. ACE, they are seen in the Glanzmanns. क्या होता है ACE? That is adenosine, collagen and epinephrine. They can be seen. If you give that, the condition may chua, right? The condition may improve, right? Let's move on to von Willebrand disease. Now this is the AD condition. What is the defect in this? von Willebrand factor disease है. So किस में defect होना चाहिए बच्चों? Obviously von Willebrand factor में defect आएगा, right? So defect is in the von Willebrand factor. What it was doing? It was helping us in the adhesion. So adhesion won't happen, right? So adhesion is not going to happen and the stabilization won't be happening of the platelets. So it basically helps to stabilize the platelets on the wall. So the platelets won't be able to stabilize. The stabilization won't be there in the platelets. Stickiness won't be there in the platelets. Unless and until the platelets and von Willebrand factor, they come together, then what the bleeding won't stop unless and until they both come together. Okay, the count won't be abnormal, they will be normal in this. There is no problem in the platelet, there is a problem in the von Willebrand factor. What will happen to the bleeding time? Bleeding time is going to increase because there is no stickiness again. Adhesion nahi ho pa raha hai. Again the problem is in the adhesion. Okay, they are not able to, just write there, unable to stabilize the platelet, unable to stabilize the platelet, and that's why the von Willebrand factor is not there, and that's why this is going to be difficult to have or difficult to stop the bleeding time. The PT will be normal. Now understand, sometimes it is seen that the APTTs increase. Why? Now tell me why the APTT will be increased. Tell me. I told you the brother of this von Willebrand factor also, which is there in the intrinsic pathway. Tell me, what is going to be there? Which slide do you want to see, Shabazz? Chalo, this was, you wanted to see adenosine, collagen and epinephrine. If you want to take the screenshot, you can take it. Chalo, APTT will be raised, I agree, but why? I'm asking the reason why. I told you APTT will be increased, but why? But please remember, von Willebrand factor and factor number 8, they are brothers, है ना, bro वाला scene है उसमें. So that's why, अरे कितनी बार last slide दिखाऊं, चलो. So von Willebrand factor and factor number 8, they are bros, right? So that's why it is unable to stabilize factor number 8 while clotting also. So APTT will be also increased. Okay, so that's how you're going to differentiate between the Bernard-Solius and von Willebrand factor disease. आप APTT देखोगे, Bernard-Solius में change नहीं आएगा, but APTT will be raised in the von Willebrand factor. Okay, ITP में क्या होगा? What are these? These are the antibodies against the platelets. So they are going to attack the platelets, right? Because of any reason, if this is happening, it is usually a chronic condition. अधेड़ उम्र के इंसान में दिखती है, that is 30 to 40 years के फीमेल में बेसिकली दिखेगी, right? Not good for females. So yeah, the ITP can be seen, especially after the pregnancy. This happens because of in the pregnancy many things happens, right? This is one of the thing which is going to happen. Auto antibodies, Coombs test positive आएगा ही आएगा, right? And this will start the platelet destruction. Platelet destruction will be start. What will happen to the platelet count, bachcho? Obviously platelets are destroyed, so platelets are going to decrease. What will happen to the bleeding time? Bleeding time is increased. CT, there is no problem in the clotting factor, so CT is going to be absolutely normal. Now bone marrow में बता होगा क्या? What is going to happen in the bone marrow? What is going to happen in the bone marrow? Main cause of prolonged APTT is it won't be able to stabilize factor number 8. Okay, Bilal? Chalo. Tell me what is going to happen in the bone marrow if the platelets are breaking down quickly. There will be increase in the megakaryocyte. So please remember, megakaryocyte क्या था? It was the precursor. It was the precursor for platelet that is going to increase. Why? Because the platelets are less. Now we need to increase the megakaryocyte so that they can butt off the platelets from them. Right? Acute condition हो सकती है. Acute में क्या क्या होगा बच्चों? 2 to 8 years में होती है. Right? So ये बच्चों में मिलेगा. बच्चों में viral infection से and findings will be the same. Just the age will be different, but findings will be the same. Okay? Increase megakaryocyte. Okay, Osama? Yes, that's good. Roy? Okay, चलो. So बच्चों में होता है तो अच्छा है ना? जैसे कॉन्फिडेंस अगर छोटे बच्चे में देखते हो तो इट इज वेल एंड गुड, राइट? कि छोटा बच्चा कुछ भी बोले चल जाता है सब कुछ. बट मैंने जैसे आई टोल्ड यू इन बिटवीन, इफ you see some confident guy roaming around here and there without studying and all with a whole lot of confidence, ऐसे लगता है लाइफ इनको धोके नहीं गई है कभी, right? So if that happens in the 30 to 40 years of female, it is going to be definitely blood. What is this? Everywhere it is bleeding, right? Or as it is happening in our brain also. So this is hemophilia. Hemophilia, everywhere it is full of blood, right? The blood is filling. So it is of 3 types. The first 2 types are XLR. The third type is going to be the AR, that is the autosomal recessive condition. All of them are recessive. The first 2 are X-linked recessive. Again 8, 9 and 11. 8, 9, 11, please remember that. Platelet count. What is going to happen to the platelet count? It is going to be normal. There is no problem in the platelet. The problem in the hemophilia is in the clotting factors. factor number 8, 9 and 11, obviously the CT is going to increase. What will happen to the PT and APTT depending on what type of hemophilia you're talking about? Remember, either that is 8, 9 or 11, three of them are used in the intrinsic factor. है ना? Clotting factor कौन से pathway वाले? The intrinsic, which is a longer pathway. Intrinsic factor में problem है, so all of them are intrinsic, longer pathway. That means APTT will be risen and the PT is going to be normal. The PT is going to be normal. Right? So this is going to happen over here. Chalo, I'm going to change the slide. If you want, you can take the screenshot of it if you have not written this. Chalo, next is platelets, coming to decrease in the platelet. So if the platelets are decreased, that is thrombotic thrombocytopenic purpura. So what is it? Thrombotic. We're about to finish, guys. Thrombotic thrombocytopenic purpura. In that, what is the defect? Defect is in the ADAMTS13 von Willebrand factor. Iska function kya hota hai? Can you tell me what is the function of this? So see over here, I'm just going to tell you what is the function of the ADAMTS13. ADAMTS13, if there is a deficiency, what is going to happen? These fibrin clots are there, na? They won't break away. After some time, once the normal thing is formed, what should happen? This fibrin clot should be cut down, so that, suppose this is the vessel, right? This is the vessel and these are plaques which are formed. Usually, as soon as the bleeding stop and the permanent plaque is formed and the endothelial cells start to form from here and there, this fibrin clot should be removed from here so that the normal flow will regain back. But if this thrombus is not removed, then this is going to cause a lot of hemolysis also. So that is going to create a lot of problem. So we want to remove this plaque. For that, whatever fibrin threads were formed, we have to cut them down. And whose work to cut down these fibrin threads? So you can see over here the fibrin threads remain like that. This work was of ADAMTS13. This is the gene which is going to form the ADAMTS13. That is going to form what thing? This is going to break away. Okay, von Willebrand factor, and this is going to combine with this fibrin thread. Basically what they do is they are going to break away the fibrin threads. Okay, so normal ADAMTS13 हुआ तो ये वाला break करेगा. यहाँ पे you can see the seizure over here which is going to break away that fibrin clot, right? But which will not happen in the case of deficiency of this. So please remember that it is basically removing this ADAMTS13. Basically it is removing or degrading the von Willebrand factor. So degradation of von Willebrand factor, and with that removal of thrombus is happening over here, right? Clinical features में क्या क्या आएगा बच्चों? Obviously, tell me, the platelets are trapped inside this, right? So fibrin में trap रह रहा है और von Willebrand factor is not able to degrade, so it will attract more and more. Pandit ji are there, so they are more attracting more and more parents, so that's why we cannot live freely, right? So that is the problem over here. So what is going to happen? Obviously the platelet numbers are going to be less, that is thrombocytopenia will be there first of all. Then there is a possibility that because of the thrombus, the hemolytic anemia is there, that is macroangiopathic. That means smaller vessels may, there is going to be, if there is a thrombus, the RBCs are going to stuck on that and they are going to break away, and that will lead to anemia, that is the microangiopathic hemolytic anemia, that can be there. Then ARF, acute renal failure can be there. There can be a fever, and with that last but not the least, that is CNS symptoms can be there. So please remember, this is the pentad which is available of thrombocytopenia, MAHA, ARF, fever and CNS system. These are the 5 things which are important, which is there in the pentad. Okay, so this is the pentad of the TTP. All right. So let's move on next. Can you guess what is this? What is these guys? What are these slides which are shown? More and more panditjis, right? So what is this shown in this diagram? Just tell me what are the cells which you can see in this slide. Okay, so first thing, HUS. HUS is hemolytic uremic syndrome. It is happening in the children, and there is an infection of E. coli. There is a special strain of E. coli, and what is that strain? It is O157 is to H7. So this is the strain, but though it is E. coli, this is going to release the toxin which is known as Shigella-like toxin. Shigella-like toxin hota hai, but that is not the Shigella virus, right? It is the E. coli, which is the bacteria which is releasing this Shigella-like toxin, which is going to break away or causing the uremic syndrome, which is breaking away the, what thing? This is going to break away the RBCs, and these are cells are helmet cell, Burr cells are there, or the schistocytes are also there. Yes, Yogi, Roy, Preksha, yes, Arefa, yes, helmet cells are there. Now, yes, it is written already, H7 is there. Shigella can cause, but it is followed by E. coli. If you have the E. coli 0, this 157 is to H7, this is a specific strain, right? Cystocyte Burr cell, already you guys tell me. Now, DIC. What is DIC? Tell me give me the answer of this question first. Which AML type, which FAB classification AML type is related to this? I told you the memorization trick also. So, please tell me that in which AML type it is related to the, yes, Roy, it is related to the AML. Yesterday we talked about this, and after, like, this is the last thing, I guess. After that, few points are there which I wanted to talk, and then we are going to solve the question, and this is going to be over in next 15 minutes, I guess. 9:15 the class over ho jayegi. Yes, Purnima, absolutely correct, bacha. Yes. So I told you 1, 2 and 3. So that's why DIC contains 3. So M3 is going to be the AML FAB3, which is going to be with maturation, right? Differentiation with maturation, both is going to be there, promyelocytic basically, right? So that is going to be there. Now what happens? See over here, formation of clot is happening and fibrinolysis is also occurring. So it is like a seesaw game, right? Both should be balanced. Over here, what is happening? The formation of clots are much more, right? So the formation of clots are much more as compared to the fibrinolysis rate. So they're much higher. So formation of clot, unnecessary clots are forming because their rate is higher. And that's why unnecessary clots are forming inside the blood vessel, which we cannot break away. And that's why disseminated intravascular coagulopathy. It's a coagulopathy. Some abnormal coagulation is happening. Where it is happening? Inside the vessel. That's why we call it as intravascular. And it is happening here and there. It's not happening where the bleeding is occurring. It's happening randomly, right? Random shit happens. So this is like a random shit condition. That is the disseminated intravascular coagulopathy. The name itself telling you that the inside the vessel randomly the coagulation is taking place. The procoagulants are going to be much higher because of the any reason, right? And the fibrinolysis is less over here. So you can see the coagulation is going to occur. Now because of that, if the coagulation is already there, most of my platelets are used to form this unnecessary things. Again, the same thing. Everybody has 24 hours, hai na? But some will study and pass the exam, hai na? Some will do the time pass, hai na? Yesterday's class, there were many students. In the beginning of the class, there were many students. As soon as I started teaching more and more factual things, most of them vanishes off, right? So what I told you is very important thing. Attend the classes until the end, right? Some of you are attending the classes, whomsoever is listening to it, not blaming you guys. So everybody has those 24 hours. Most of the guys will say that we'll see the class later because it is, I don't know what, right? Many factual things are there. But that later never comes. But whomsoever sits with the patients, right, and they continue the class throughout. That Sanjay guy is not there, right? Not even commenting anywhere, right? He is also gone. So that 24 hours, we need to decide that what we are going to do with that 24 hours. So platelet numbers, why I'm telling you that the platelet number is going to be there, right? So the platelet numbers are going to be there, but they are also limited. Now, if we use up that to form the unnecessary clotting, right? So, किसने क्या बोला, किसने क्या किया, कल क्या खाना है, क्या पहनना है, just they are unnecessary things, okay? Just don't pay attention to it, right? Many people say me, ma'am, ये कर लो, वो भी कर लो, ऐसे भी कर लो, वैसे भी कर लो. If I feel that unnecessarily, I won't be investing my time. Okay, there was a quote that if you are taking my time or wasting my time, you are stealing out of me, right? So do not let anyone to steal your time. If I do not feel that I'm learning something or I'm having some kind of enjoyment, be that in any matter, I won't be investing my time. I do not go to many parties and all these things which people already used to do it a lot. है ना, department में भी बहुत चलता रहता है, but I don't go there, right? I invest my time to make my content better, to add some animation, to add more images so that it will be helpful. As I told you in the third slide that my friends are learning, I should do the hard work too, right? So, if you use the platelets unnecessarily to have that DIC, what is going to occur? That definitely wherever it is required, whenever it is required, we won't be having that. So, platelets are used up unnecessarily. So, we are lacking the platelets to stop the bleeding now. So, bleeding will be occurring at one side and DIC. So, this is a contradictory thing over here. This is something, a paradox which is taking place, that unnecessarily where it is not needed, the platelets are coagulated, right? The people, most of the people, they are taking very low quality entertainment, है ना? Entertainment करना है तो कुछ medical related jokes सुनो, right? Memes बनाओ, wall को पढ़ाओ, right? Do some fun activities with your friends. Ask the question. If you are get bored, see the images, right? So same thing. If you invest your brain into unnecessary things, where it is necessary, it won't be there in your brain. So same thing is happening in the DIC. So it is also known as DIC is also known as, yes guys, anybody, can you tell me DIC is also known as? Just give me the comment, because still I am teaching the DIC in this. So yes, postpartum hemorrhage, that is possible, malignancy, AML, this is going to occur. So platelet kya hoga? Obviously the platelet numbers are going to decrease because they are already used up. And please remember, the DIC is taking place, that means fibrin clots are formed. Fibrin clots are formed, but they are unnecessarily. There is no problem in the Adam TS13 that is going to break away that, right? And that is going to form fibrin degradation products, right? Bleeding time ko kya hoga? Bleeding time is going to increase because those platelets are forming unnecessarily clots and not the necessary ones, right? So CT, PT and APTT में क्या होगा बच्चों? Obviously clotting is not occurring per se. So what is going to happen? Again, they will be used up. Clotting factors are used up to form the clots. Why? Because the platelets were attracting and activating the clotting factors also. So CT is going to increase. FDP and D dimer is going to increase. The D dimer actually checks what is the level of FDP. So that is going to be the investigation of choice. Yes, it is also known as, anybody gave the answer? अरे बिलाल, ये तो नाम है बच्चे. It is known as consumption coagulopathy, right? The platelets are consumed, right? So it is consumed, but coagulopathy, wherever it is not required, they are consumed, and wherever it is required, it won't be there. Okay, so that is going to be there. Now it may cause, if they go in the lung congestion may occur, but remember, जो cells दिखते हैं, that they are going to be heart failure cells, right, which are containing the hemosiderin. These are the macrophages, heart failure cells, right? The last two slides will be there. Liver में जाके अगर block कर दिया इन्होंने, disseminated intravascular coagulopathy can be possible there. So nutmeg layer will be there. So you can see over here heart failure cells. Please remember, though it is written as heart failure cell, they are not seen the heart failure, rather they will be seen in the lungs. Okay, so macrophages with the hemosiderin, that is going to be there. Congested capillaries will be seen at the side. Alveolar septa is going to be thickened. Unnecessary thing, alveoli containing hemosiderin laden macrophages. They are loaded with the hemosiderin, and that's why we can see this orange brown color hemosiderin which is going to be there. These are known as heart failure cells. This kind of an animated slide, I'll show you the normal slide also. They will be this orangish and brown color pigments, and these are what? Alveoli surrounding them. So you can see these are the alveoli. So that's why they are in the lungs and not in the heart, but they are said as to be heart failure cells. Okay, so this is last slide. We are going to do some quick questions. And then we are going to end up the class. Okay, so if you do not feel like solving the PYQs, please tell your mind there is a solution and it will find it for you. Okay, so mind को बोलो कि कोई solution जरूर होगा, तो mind अपने आप उसका answer ढूंढ निकालेगा, right? So you, as I told you yesterday also, tell your mind that there is a solution and the mind will find it for you. Okay, so let's solve some question. You are going to tell me the solutions. Chalo. Chalo, tell me, what is the Virchow triad? If the endothelial lining is smooth, there will be no bleeding, right? But endothelial lining, if it breaks away, definitely the problem will start. I don't know what chat is going on. I missed something maybe. Chalo, Virchow triad batao. We haven't covered that in the D. Mind is not listening. Okay. Then write it down. It may see what you are writing there, right? Chalo, Virchow triad include all except. You guys are right. So endothelial injury हो जाती है, तब क्या होगा? The endothelial lining is no more smooth now, right? It is broken. So endothelial injury होगी. उसके बाद क्या होगा? यहाँ पे the thrombus will be formed, hypercoagulability will be there, and over there, if this is a vessel and the blood flow was going on, then there will be stasis of blood flow. All these things will be occurring there. The only thing, since they ask us except, the platelet thrombus is the not part of it, but hypercoagulability will be there. So please remember Virchow triad. Burkitt's lymphoma. Tell me what about the Burkitt's lymphoma? Yes, Haripriya, Divya, Ashwini, Sonu, Tanya, Anurag. Yes, Purnima, Preksha, Bilal, Arefa, you guys are right. AZ, A to Z, right? The next question is there, Burkitt's lymphoma. Tell me, मैंने कल pneumonic भी बताया था आपको. I told you 14 will come many times. Mental में हमने पढ़ा था LEEL, right? So I was listening to some memes yesterday. So that was, I don't know how many people know the khichdi. Yesterday I just came across that GIF. Somebody told me that one character is there, I don't remember the name, but she is going to ask that Praful that what is the elevator, right? So he says Hansa, Hansa. He says that elevator, Hansa, elevator. So when I give the bill to the waiter, what we call it as elevator, elevator. So that was funny, but I don't know how it is working out for them. Okay, yes guys, you are absolutely right. It is the I told you B comes with 8, right? It looks like 8 and Burkitt's 14. 8 is to 14. Definitely that is the answer. Which among the following is true for hereditary spherocytosis? Chalo, batao. We talked about spherocytosis. Yes, Sonu, you are absolutely right. Overexpression of MIC-C. So, chalo, batao. Hereditary spherocytosis mein what is going to happen? What is the answer, bacho? C-MYC mutation. Starry Sky, HP, good, good, good. That means you guys are revising. Very nice. So osmotic fragility is going to increase. There is only one condition. मोटू में और भरोगे तो फ्रजाइल है, वो बहुत फ्रजाइल है ना. मोटू वाले लोग क्या होते हैं, बहुत फ्रजाइल होते हैं, फट से फट जाते हैं, राइट. सो जिनका मोटी बुद्धि होती है वो फट जाते हैं, बहुत इजीली फट जाते हैं, राइट. सो प्लीज रिमेंबर स्फेरिकल सेल. देन डिक्रीज किस में होता है? SIT आई टोल्ड यू, सिकल सेल एनीमिया, IDA एंड the thalassemia. Okay, then following type of bodies are found in. चलो जी बताओ फटाफट, किसमें this can be seen? This cell is seen in. Shall I hope you will give the answer? Yes, Purnima, right? Proud FMG. Yes, we should be proud, है ना? Tanya, Aryan, wonderful. So यहाँ पे क्या आंसर होगा बच्चों? Important tip is just try to solve the question every day. Pets world, okay? That is only important thing. Just convert your study time into the worry time into study time. That is the only thing. Worrying is just a, I think it's a waste of emotion and waste of time also. So whatever you are investing the time into worrying, please change that into study time, है ना. वरी करने से कुछ नहीं होगा कि कुछ याद नहीं आ रहा, आ जाएगा, है ना. Convert that time into study time. That is the only thing. And the second thing is solve the PYQs, है ना, previous year question, because again the government wants you to know a particular topic in detail. At least superficially they are going to, those topics will be repeated, you'll get an idea how to solve, and some silly mistakes will be avoided while solving the PYQ. So the only thing I wanted to tell you that trust yourself, convert the worry time into study time, do not waste your time and solve the PYQs. Okay, I'm getting the answers. Yes, it is not the sickle cell anemia बच्चों, it is the G6PD, है ना. sickle cell में sickling दिखेगी. These are not sickle cell shaped, right, sickle cells. And what you can see over here is hinge body, which we can see in the G6PD, right. चलो जी, next बताओ. Given type of leukemia, it is not actually a leukemia, it is misnomer, right. But yes, what cannot be seen? So least possible क्या हो सकता है? Go with the flow. Yeah, but you have to make the flow. चलो next का आंसर बताओ. Yes, you guys are right. Hairy cells, these are looking like hairs, and this is going to be lymphadenopathy. Yes, Shabaz, Sonu, Osama, Roy, Anurag, Purnima, Divya, Bilal, Arefa, Ashwini, Preksha. Yes, vlogs. Someone. Someone, right. This is also right. Extrinsic किससे करते हैं? मैंने क्या बोला था? X को कम टाइम देना चाहिए, ज्यादा टाइम देना चाहिए? चलो बताओ. Extrinsic का आंसर बताओ फटाफट. Not characterized by पूछा था बच्चों. Don't get confused. I got the answers as hepatomegaly, not characterized as लिखा हुआ है, तो lymphadenopathy होगा, है ना. It hepatomegaly and splenomegaly will be there. Pancytopenia will be there definitely, but not the lymphadenopathy, है ना, क्योंकि वो lymph से बाहर आ जाता है. Please remember what is going to happen is, though it is a lymphoma, but remember that it is produced in the bone marrow, right? And then they will go and lymph में जाके mature होते हैं. But over here what is going to happen is they won't go there and they will remain in the blood per se. Okay? चलो इसका क्या आंसर था? एक्स को कम टाइम देना है, भूल जाना है, राइट? बट ओवर हियर वी आर taking it as PT not APTT. Okay, TT कुछ होता नहीं है, bleeding time is BT. BT हम platelets के लिए करते हैं. This is for the platelets, not for any pathway. Pathway जब भी हम करते हैं clotting factors के लिए करते हैं, right? चलो next is garden party appearance. बताओ garden party किस में आती है बच्चों? Garden party appearance. Few slides only, 5-6 slides more. BRAF mutation, yes, true. Garden party appearance किस में आती है? चलो, I hope you will give the answer. Yes, garden party is seen in the, yes, you guys are right, CML. Supravital, vital जहाँ पे भी नाम आया, we discussed that where we are going to use not per se RBC but specially the reticulocyte, because reticulocyte requires, reticulocyte का बहुत ज़्यादा capacity नहीं होता है to remain in the room temperature, so that's why we have to provide, this is a precursor cell, so they need the warmth. Okay, reticulocyte. I hope you will give the answer. You guys are rocking. What is the most common protein deficiency associated with hereditary spherocytosis? I told you, अच्छे लोगों के साथ अच्छे लोग नहीं जाते हैं, right? So spherocytosis के साथ spectrin नहीं जाएगा, यहाँ पे Antigen जाएगा. Okay? Garden party favorite. Cool. A patient, ये देखते ही आपको पता चलना चाहिए क्या है ये. देखते ही spoon है तो B12. स्पून होगा तो B12. इवन यू डू नॉट नीड टू रिमेंबर और रीड द क्वेश्चन, है ना? स्पून शेप नील शो किया है तो डू नॉट थिंक ऑफ एनीथिंग एल्स, जस्ट गो एंड मार्क द विटामिन B12. ओके, ये कौन सा अपीयरेंस है बच्चों? यस, एस नेवर गो विथ एस, आर्टिस्ट, राइट? पूर्णिमा, बच्चे आयरन डेफिशिएंसी होगा क्या? फिर से सोचो. आयरन डेफिशिएंसी में ना लॉन्गिट्यूडनल स्ट्राई आते हैं, स्पून शेप नहीं होते. B12, B12. ओके, ये कौन सा है बच्चों? यस्टरडे वी रेड अबाउट द हनीकूम अपीयरेंस, है ना? सो ये कौन सा लग रहा है आपको? व्हाट इट इज सीन एज? इट इज माइलोफाइब्रोसिस, है ना? योर फेवरेट गर्ल, फेवरेट गर्ल किस में आएगी? गोल्फ बॉल कहां से आ गया यार? माइलोफाइब्रोसिस था उसका आंसर. सी सी, माइलोफाइब्रोसिस. हनीकूम अपीयरेंस, आई टोल्ड यू कि यहाँ पे कोई सेल्स नहीं दिखेंगे आपको, ये खाली खाली दिखेगा, राइट? सो दिस इज अ हनीकूम अपीयरेंस. एंड अगर आप यहाँ पे ध्यान से देखो, फ्राइडे का अपीयरेंस भी दिख रहा है आपको. ओके, चल, everybody is right, thalassemia. So last and not the least, that is a little progress each day adds up to the big results. And with that message, I am done with the hematology, and definitely 5 to 6 question will be coming in your exam. For last days, just have the faith, everybody will be worried, है ना? In last days, what happens is many students get anxious and they leave the preparation with the fear, है ना? So that is how you are going to differentiate. The first slide I showed you in the hematology, that is differentiate yourself from the others, right? Many of the persons, suppose 100 students are there, almost 50% of the student will give up in between. Why? Because they will be more afraid. They think as if the anxiety is increasing as they are reading. Don't worry, it's okay, it's in your hand to read, just read it out, whatever. Even if you read let's say one subject, one small subject is done, at least you solve one GT or one SWT, fine, you're doing something. Just don't waste your time. Whatever is seen, images देख लो, charts देख लो, whichever subject is you seem to be interesting, वो देख लो. Whatever you feel like, just do it. Just read it. Read करने का मन नहीं करे तो video देख लो. Just do it. But I'll suggest that reading is more important now. If you saw the video once, just do not see it video again, because this is kind of a passive learning. Okay, the teacher is teaching you, then you'll understand. But please solve at least 30 to 50 MCQs per day. ज़्यादा टाइम नहीं लगेगा, half an hour, 1 hour will be sufficient, and try to sit as long as possible. 3 hours का set करो और बैठने की आदत डालो. Okay, that is more important, because again after 1.5 hour, 2 hours, your brain will be roaming here and there. It won't be concentrated. Mind को आदत डालो, and that is what I wanted to say. Right, that is all from my side, and thank you very much. I hope you like the session. कुछ improvement के cases है, suggestions है, you can. Okay, bye bye.